traveling patient requesting antibiotics. I've done these previously as well, but I want to do it again because of the request from some candidates that they were not able to attend the last one. So traveling requesting antibiotics, there are some from rheumatology. These are metatarsalgia, Morton's metatarsalgia, plantar fasciitis, hyperhidrosis, ALS, requesting riluzole, frontotemporal dementia, then Huntington's, general anxiety disorder, menstrual migraine, hyperemesis gravidarum, granulocytosis, lithium toxicity, endometritis, mesothelioma, the cancer, Down syndrome, essential tremor, MALA, cradle cap, OCD, infective endocarditis. This has come as a history station as well. Then medication overuse, headache, acne. That is, acne station is there for very long, but this station is a bit different. It's a male patient coming and he's using some medication, which could be the reason of acne. And UTI in a female child, the drug of choice, antibiotics, I'll discuss that. Another is epistaxis. So these are the scenarios. And the rest three, reactive arthritis, intestinal obstruction, PSA, that's already there in your book and everything. I'll explain because I will explain it in a bit. Why? Because there has been some changes in the scenario, some findings they're giving it to you in the cubicle. So I will try my best to explain those findings quickly. So, I mean, we are going to discuss till this point. Last three is just a 2 minutes job, right? So that is what we have got in the new scenarios, right? Yeah, let's begin then, yeah? All right. So the first one we have got is the patient is traveling and requesting for antibiotics. Okay, so you are FY2 in GP surgery and the patient is 48 and they have he has made an appointment to see you. The task is to talk to him, assess him, and address his concern. So you will see nowadays most of the tasks are like this only. They won't be giving you, I would say, enough information in the question. What will be given to you in the question? That patient has got some concerns. That is it. Okay. So the task is patient has made an appointment. So how can I help you? The patient is like, I'm going on holidays to Thailand and I want to get some antibiotics to take with me just in case I develop any infection while I'm there in Thailand. Now, see, in the UK, giving antibiotics is a big thing. They don't give it to they don't give it to us just like that. There has to be a reason behind it. That's why, like a lot of us, whenever we come to the UK, what we do, we get a lot of antibiotics with us because we know here, if you're going to go to the GP, you're not going to get antibiotics that easily, right? So usually in this station, as patient is requesting for antibiotics, so usually we don't have to give. However, in most of the scenario, wherever, even if it is a reassurance scenario, even if you have to say no, you have to rule out some of the criterias because there has been some there are some criteria where you might be giving antibiotics to these patients as well. So what I mean to say is whenever patient is requesting for something, do not deny straight away. Acknowledge, I can see you are going to Thailand and you want some antibiotics. Let me ask you some questions to see if you really needs it or not. So that is something that you need to do. Acknowledgement, and more of acknowledgement. Do not come to the conclusion of any station in the beginning. Just take a bit of time building that rapport, right? Now, what you do, take a bit of history. So patient is planning to travel. The person is planning to travel. So when are they planning to travel? That's one thing. And we have got some vaccination as well, travel vaccination as well. So you can ask if they have taken those traveling vaccination or not. One thing for travel vaccination, I would say, travel vaccination is not like you can just take it now. So usually travel vaccination is usually given 6 to 8 weeks prior to travel. Right. So that's why it makes sense to ask, when are you planning to travel? Because if the patient is saying, I'm traveling in 1-2 weeks, will you be able to give any vaccination thing? Not really. But yes, in the future, if patient is planning to travel, so at least you can say before traveling 6 to 8 weeks, you come to us so we can give you some vaccination that might be quite helpful, right? So who are you traveling with? That is really important. And if your wife has taken the vaccination or not, and if you are up to date with your regular vaccination or not. So these are the main things. These are the main questions that you can ask. So patient is saying, I want some antibiotics. And so you are asking, patient is saying, I want antibiotic because I'm traveling to Thailand just to make sure I don't get an infection. So when are you planning to travel? Have you taken any vaccination or not? Whom you are traveling with? If your wife has taken a vaccination or not? Are you both up to date with the vaccination or not? Right. Now, patient is worried about infections. Which infection? That is really important for us to know, right? So, which infection? So, patient is saying, I'm worried about stomach and the chest infections. All right, that's okay. Now we need to know, do we have any criteria where we may be able to give antibiotics to these patients prophylactically? That is what we have to find, all right? So what happens is usually we don't, but prophylactic antibiotics is given to whom? The person who is immunocompromised. If the patient is immunocompromised, you may be able to give prophylactic antibiotics. So if the patient has got some GI issues like Crohn's disease or ulcerative colitis, if patient has got ileostomy, colostomy, obviously the chances of having infection is going to be high. So in these cases, we might be able to give it, right? And then diabetes, or if the patient is having any cancer, obviously diabetes and cancer is going to make the patient immunocompromised, and sickle cell disease, right? So if any of these things, any blood disorders, right? So if any of these things exist, you will be able to give prophylactic antibiotics as well. So that's why, whenever you get these kind of station, do not deny it in the beginning straight away. I've seen like whenever I practice with some candidates, and we get these kind of station, I want antibiotics because I'm traveling. No, we can't give antibiotics. Come on, you can't come to the conclusion straight away. First couple of minutes, build the rapport and try finding if there are any risk factors or not, right? So this is what you have to do. If the patient has been diagnosed with any medical condition like any diabetes, any cancer, any sickle cell disease, any blood disorders, right? Any GI issues, ulcerative colitis, Crohn's, you need to ask those questions, right? If patient is taking any long-term medication like say steroid, if patient is on steroid, what's going to happen? Their immunity is gonna be low again, isn't it? So that is why these questions are really, really important. So if you get any of these things, answer is yes, I can give it to you. But if the patient is not having any of these things, then what I'll say, unfortunately, we won't be able to prescribe. It is against the national guidelines, and it's not a good idea to get it. Right. But sometimes patient says, I went to Brazil last time and was given antibiotics. Why was that? So the thing is, you can ask the patient again the question, say, I'm not sure why you were given. So which antibiotics were given last time? May I know what was the exact reason why the doctor has given you antibiotics that time? So you can ask all those questions, but obviously we are not going to give antibiotics if it is not fitting into the criteria. Okay. Right, so it could have been for a specific prophylaxis or due to the particular indication at that time. Without knowing the exact details, it's hard to say, right? So we don't generally give antibiotics in terms of diarrhea and all. And you can also ask if the patient has got any medical insurance and all. That would be very, very important. And for example, patient is traveling to Thailand, so we can talk about the mosquitoes as well. So they can use like insect repellent and wear long sleeves to avoid bites. So if you have time, maybe you can talk about these general things as well, right? Now, this patient has got some concern. This patient has got some concern. This patient is asking, can I take loperamide? He's using the word Imodium sometime. Can I use loperamide as a prophylaxis? That is the question that patient is asking. So if you get diarrhea, then maybe you can take loperamide. Usually it's not recommended. What they say, if a person has got diarrhea, the thing is, we have got the infection in the stomach and it's coming out. So they say, let it come out. We try not to give any medication to stop diarrhea. All right. However, if it is kind of urgent, you are going for an important meeting, you have got a concert to do, right? So in those cases, maybe yes, but can I use loperamide or Imodium as a prophylaxis? The answer is no, it cannot be, right? And tell the patient, consider buying some ORS in case if you get some problem, right? But vaccination, as we know, it is given 6 to 8 weeks prior to the travel. So that is something that you can ask in the history as well. Another thing is if the patient is on any chronic medication, right? For example, patient is taking the medication for anything, for high blood pressure, for anything, is he gonna get the full supply from the NHS? So NHS accepts responsibility for supplying the ongoing medication for the existing medical needs for temporary needs for around 3 months. So the patient is taking any medication for any chronic illness, they can get the supply for 3 months, not more than that. The patient is saying, I'm traveling for 6 months, they will be getting it for 3 months only, right? So that is it. So vaccination, as I said, you have to get it 6 to 8 weeks prior. But where you can get the vaccination, you can contact your GP. You can get it there. Vaccinations are available free on the NHS, including these polio vaccination, diphtheria, tetanus, typhoid, hepatitis A, cholera. But for some of the vaccination, you may have to pay as well. So for hepatitis B, Japanese encephalitis, meningitis, rabies, tick-borne encephalitis, you may have to pay as well. It's not like everybody has to pay. Some of the patient might have to pay as well. Right? Now, there is something called standby antibiotics, right? So where access to the standby antibiotics usually given when access to the medical assistance is poor or not available, right? So for example, you're going in an area like you're from the media, you're a journalist, and you're going to a place where you know the medical assistance is not available properly, not proper things are available. In those cases, you might be given standby antibiotics. Okay, so now what we need to know, I know we have learned a bit more in this. So what we need to know, patient is requesting antibiotics because of the travel. So you have to ask, where are you traveling? When are you traveling? Are you up to date with your vaccination? Do you have your medical insurance? Whom you are traveling with? If they are up to date with the vaccination or not. So here are the questions that you can ask, right? Then you ask if the patient is immunocompromised or not to see if you have to give antibiotics prophylactically or not, right? So check if the patient is immunocompromised or not. Then what you do, you take quick past personal history as well, right? And then we tell the patient it's advisable not to have the antibiotics because we don't usually give it. It's against our national guidelines and it can make you resistant as well, right? But there are a few things that you can do from your side is take these things with you, like ORS maybe, right? So that might be quite helpful. And in future, if you're planning to travel, let us know in advance so we will be able to give you some extra vaccination as well, right? That's the thing that you can mention. Doctor, can I take Imodium loperamide as prophylaxis? The answer is not really. Right. And that is it. So that's what you do in this particular scenario. Traveling patient requesting antibiotics. All right. Okay. Let's begin the next one. So we have got Morton's metatarsalgia. Metatarsalgia or Morton's metatarsalgia, right? Or Morton's neuroma. Right. So what patient is saying? Patient is in the GP. Our patient is 35, has come to you with the complaint of pain in her right foot, pain in the right foot. Talk to the patient, assess the patient, and address her concern. Mostly you'll have a female patient when we are dealing with Morton's neuroma, right? So GP 35 female complaining of pain, right? So what we have to do here when you start the station, how can I help you? I've got pain in my feet. Fine. So what do you do when pain is there? So don't go with which foot straight away. So what you do Socrates straight away. Socrates. Yeah. Elaborate this pain, right? So I've got pain in my feet. So tell me more about your pain, right? Then you need to know like which foot, like is it right or left? What kind of pain it is, if it is going anywhere, if anything makes it worse, anything makes it better. So all those things you're going to ask. So what you did full Socrates and then asking for the scoring as well, right? And if the patient has tried something before to relieve this pain or not. Because if the patient is going to score it, at least I'll get a bit of idea, isn't it? Like in terms of painkiller, which painkiller I should be prescribing? Should I go with the higher painkiller or should I just give normal painkiller? So that is really, really important here, right? And then anything else? Once you're done with the elaboration of presenting complaint, the next question that you will have is anything else, right? So nothing else, doctor. Now what you can ask some other questions as well, just to see like if patient has got any numbness, tingling, right? Because that is specifically for Morton's neuroma. Right. So Morton's neuroma, Morton metatarsalgia usually happens where it's on the second or third or between third and fourth toes. Let me show you a picture that will make life easy for you. So Morton's neuroma. So here you will have the pain usually. Second or third or fourth toes. So this is the particular area where you will have the pain. Why this happened? Because of the shape of your leg like this. So why my feet is like that? Why my foot is like that? Because the patient is wearing high heels. So you will see it is more common in women, corporate women, those who have to wear the heels and all. So that's why you will see the pressure is going to be there in the toes area between second, third or fourth. So this area pain is going to be there. And that can actually lead to this Morton's neuroma. All right. So what you're going to do, I have pain. I'm going to do the elaboration Socrates. And this patient is telling us that it gets worse. This patient is saying when I'm wearing the heels, it is very bad at that time. But my work, I'm working in a corporate office, so I need to wear heels as well. So that's making my life really, really difficult. Okay. Now, there are some risk factors as well. Risk factors is one I said is wearing a tight, pointy, high heel shoes. That's one thing. If you're doing excessive running, or if you have got flat feet, high arch feet, bunions, or hammer toes, or if you are overweight, that is really, really important. So, overweight, so that's what I'm doing, gonna do. I'm gonna do a very quick past medical history as well. And when it comes to examination, I will definitely mention about BMI as well, right? Okay, so pain, what you're gonna do, you're gonna elaborate pain, Socrates, anything else, no doctor, then I'm gonna ask if there is any numbness, tingling. If there is numbness, tingling, it's gonna go more towards a Morton's neuroma. That is the main thing. Okay, so see, what is Morton's neuroma and what is metatarsalgia? Metatarsalgia, I would say it's an umbrella term. Let's read it. Metatarsalgia, it's a general name given to the pain in the front part of your foot under the head of your metatarsal. Morton's neuroma is a possible cause of metatarsalgia. So metatarsalgia is a big umbrella term. Morton's neuroma is a part of it. So that is why, when you have a case of Morton's neuroma, mostly you will see doctors, we say it is Morton's metatarsalgia. So the name that we give is Morton's metatarsalgia. So when you elaborate it, when you give the diagnosis, you can give the diagnosis of Morton's metatarsalgia as well. So if the patient is just having pain, not having this numbness, tingling, it is just simply metatarsalgia. But if patient is giving you the numbness, tingling as well, then you can say this is Morton's metatarsalgia, right? And also you'll be able to feel the lump under the feet feeling and swelling, redness, hotness that I'm going to ask. Please ask for some differential like septic joint. So just ask for any fever as well. That is really important, right? Please cover these risk factors because patient is going to ask you in the later part of the station why I'm having this problem. So you have to have something to blame, isn't it? So that's what you do. Then go for quick past personal lifestyle history as well. That's very important. Psychosocial, why it's important? Because what is the job occupation of this patient? Because one of the risk factor is wearing tight point heels, right? Another PMHs, so ask about this if patient has got any past medical history, which can lead to obesity and all. So that's really important as well, right? Then I would like to do general physical examination, vitals, BMI, as I said, you need to mention, and the examination of the feet. And I would like to do some routine blood investigation and maybe the X-ray of the feet as well, right? And then accordingly, you'll be able to give the diagnosis. All right, so we are suspecting you may have Morton's metatarsalgia. It is a thickening of the tissue around the nerve in your feet that has been irritated, and that's why we may have pain in this particular area. That is it. All right. Now, what's the treatment? Treatment is very easy. Treatment is simply you do price. Yeah, we know that ankle sprain treatments, the same thing you have to do here as well. So painkiller, that is one thing, right? So rest, that is important. Ice pack, yes. Compression, yes. And keep your feet elevated. So that is the treatment. Price. So conservative treatment, so you can avoid wearing these heels as well. So it's better if you wear wide shoes, low heel. That is the main thing. And in the market, on the Boots pharmacy, you'll be able to find some pads as well, metatarsal pads, which is, so for example, if you have got flat feet, so if you wear these metatarsal pads, you will see it is much better and you won't have the pain, right? Pain management, obviously, and surgical options. I don't want you to give surgical options straight away, but yes, if it is severe pain and all, we might be going for this as well. But I don't want you to mention because first thing that you're going to mention is the conservative treatment, obviously. All right. So that is the main thing. So that is your treatment. Price is your treatment here. All right. Okay. So, and it usually happens, as I said, in second to third or between third to fourth dose. Right. Now we have got another scenario here is a plantar fasciitis. Have a read to this. You are FY2 in GP surgery. Patient is again female patient, 48, and came with the pain in the heel. Talk to the patient, address her concern. Right. So pain in my feet. So what I'm gonna do, I'm gonna do my Socrates. Let's see, let's do the full Socrates first. See the character of the pain, what makes it better, what makes it worse, right? So all those things I need to know. Patient said mostly it is in the heel area. Okay, when I take my first step in the morning, this thing, especially when I take first step in the morning, this is a clincher for you. So you are sleeping, you woke up, and when you put your feet on the ground, you started having the pain. That is classical history for plantar fasciitis. Okay, so what we are doing, if you do a proper Socrates, you will have your diagnosis with you. What is plantar fasciitis? See, this is the inflammation of this fascia, inflammation of this ligament, this band. So this band, actually, this band, if you see, it is connecting your calcaneum, your heel to the toes, right? If there is inflammation of this band, this is what we say plantar fasciitis. Usually why it happens? Because of flat feet. That is one of the main reasons. So if you put this picture in your mind, I think you'll understand what plantar fasciitis is. So we have got a ligament, we have got a ligament which connects your heel to the toes. When there is inflammation of this ligament, it is going to lead to plantar fasciitis. Right? That's the main thing. Risk factors, obviously increase physical activity if you are doing. Flat feet, this is one of the main reason for this. Right? Obviously obesity and flat shoes if you are wearing. So that can lead to this plantar fasciitis, especially when I take first step in the morning. That's your clincher. That is what patient is going to tell you. Right? So, whenever you get any station in your exam, you simply have to elaborate the presenting complaint. And I promise you, like mostly you'll have the diagnosis with you. 90% of the times you'll have your diagnosis with you. I'll ask some more questions like any numbness, any tingling, any redness, any bruising, any fever, flu-like symptoms, any redness, hotness in that area. I'll just do that associated symptom history as well. Okay, then go for quick past personal history as well. Why? Because obesity and all, you need to definitely work on to that. So general physical examination, vitals, mention about BMI and the feet examination as well. Then you can give your diagnosis, that plantar fasciitis, which is the inflammation of the thick band of tissue that runs across the bottom of your feet that connects your heel bone to the toes. That's it. That's it. So it is a band of tissue which connects your heel to the toes. When it gets inflamed, it can give you this pain. That is what we call plantar fasciitis. As simple as that. Right. What's the treatment? Treatment is again the same. So you have to have painkiller. You have to have rest as well. You can use ice as well, and elevation, you can mention that as well, right? And same thing here, we have got like tell the patient, I mean the flat feet is there, right? So what we can do here, they can wear some comfortable pads, right? The orthotics like arth support that you can get from the Boots Pharmacy, as I said. So that will be quite helpful in the management of plantar fasciitis as well, right? Have a look at this picture. I think that will make your life easy, right? So plantar fasciitis is the inflammation of this fascia, and pain is going to be in this area, right? Whereas when we get Morton's neuroma, pain is going to be in this area, at the back actually, on the heel, on second, third, or third, fourth metatarsal. So there is the pain. Why? Because of heel. Patient is wearing high heel, pointed heels, and that's the main reason. All right. So that is what we have got in Morton's metatarsalgia and plantar fasciitis. All right. Okay, so hyperhidrosis. Your FY2 in GP, your patient is 17, has made an appointment because your patient has got excessive sweating. Talk to the patient, assess and address her concern. Hyperhidrosis. So patient has made an appointment. Sometimes they will just tell you in the question that your patient has got some concern. Go and talk to her, assess her and address her concern. So you may not have the presenting complaint in the question. All right. Now, how can I help you? Doctor, I feel embarrassed. Sometimes they don't open up straight away. I feel embarrassed. So you just have to tell them it's a safe place. Tell me what's happening, what is making you embarrassed. I'm here to help you. And if you tell me what's happening, I'll try my best to help you in every possible way. Okay. Then patient is saying, I'm sweating a lot and recently it's getting worse. I'm sweating a lot and it's getting worse. Okay, tell me a bit more. So what do you want to know? So for how long you've been having it? So it's going to be doctor many years. It's been 2 years. Then I'll do quick OD para, right? So if you have pain, you do Socrates. If you have got other problems, we go for OD para, right? So ask like if it is getting worse, is there anything that makes it worse? Is there anything that makes it better? Doctor, stress and heat makes it worse. Okay, that's fine. And where exactly do you get the sweating? That's really important as well. So patient is saying like it's in the palms or underarms. So that's really important as well. Now, hyperhidrosis, having a bit of sweating in the palms and underarm, it's not something abnormal, isn't it? It's normal. You'll see in a lot of patients, a lot of people actually, including us, we may have it. So there's nothing much to worry if it is primary hydrosis, hyperhidrosis. But the thing is, in these kinds of scenario, what they are looking for, are we trying to rule out the secondary causes of it or not? For example, you have a scenario of Raynaud's as well. So Raynaud's, mostly it's primary Raynaud's phenomenon, right? But what in the exam, what they're looking for, are you ruling out the causes of secondaries or not, like secondary Raynaud's phenomenon? Same here, hyperhidrosis, mostly it's primary. Primary means there is no cause behind it. But still, you need to rule out if there is any underlying cause or not. So hyperhidrosis, excessive sweating, you can have if you have got fever, if you have got TB, for example, you get sweats, night sweats and all. So you have to ask if there is any fever, night sweats or not. Cancer, what you have, you can have all these things as well in cancer as well, right? So that's why you need to rule out these things. Thyroid, if you are having thyroid problem, then again you can have all those things. And your patient is female as well, so it even make more sense for us to ask about these things. Okay. Okay, so before we go into further into this, what are the risk factors actually? So risk factor for hyperhidrosis, number one, it actually runs in the family. There's a familial history, that's really important. Often starts in adolescent age, right? Associate condition, it is usually associated with the stress and anxiety. Some patient you will see because of obesity or hyperthyroidism, they might have. Some patient, they are using some medications, certain medication like antidepressants that can make it worse as well. So that is what you need to do in the history, right? Diagnose primary focal hyperhidrosis when focal, visible, and excessive sweating occurs at least one of the following site: axilla, palm, soles, or craniofacial region. And it lasts for at least 6 months and has got no apparent cause. Because if there is an apparent cause, it is not primary hyperhidrosis, right? And it has to last at least for 6 months if it is in axilla or palm. So if you see our patient, what our patient is saying, she's saying, I've got the sweating, excessive sweating in my palms and the axillary area, and it is there for last 2 years, right? And has at least two of the following characteristics. It's bilateral and relatively symmetrical, because if it is unilateral, it can have some secondary reason behind it. If it is impairing your daily activities and frequencies of at least one episode per week, onset before 25 years of age, positive family history, and cessation of local sweating during sleep. So when you are sleeping, you don't have any problem. But when you are awake, you have the problem. So it means it's primary. I mean, there is no other cause behind it. Because if there is something like, say, TB or cancer, even if you're sleeping, you will have the sweating, isn't it? So that is the main thing. So our patient, definitely, what you need to do is you do ODPARA. When you do proper ODPARA, what you will see that it is primary. But you still try asking some questions if there is any fever, any night sweats, any weight loss maybe, any loss of appetite, any tremors, any eating more than usual for thyroid and all. So this is something that you can ask, right? And try ruling out some risk factors as well. If the patient is stressed or not recently, right? Or family history of anything or not. So that is something that you need to cover. Then I would like to do general physical, vitals, and obviously you'll check the affected area. And I would like to check your full blood count. You can check for thyroid. You can check for HbA1c as well. Okay. And then we can say like you have got hyperhidrosis, and this is like something. This is like you're sweating more than usual. Can affect your hands, your axillary area, and sometimes our facial area as well. So what is the management? Management is nothing much. Management is lifestyle changes. So what is the main reason this patient is telling? Stress and heat. So work on the stress management, yoga, meditation, and work on the heat. So don't go in the heat. Maybe cover yourself, and all that would be much better. All right. So practice stress management techniques, relaxation exercises, and all. Wear loose, breathable clothing. Avoid hot and spicy food that might increase sweating. Right, and usually topical treatment. We advise the patient to go with this aluminum chloride. So that is something that you can get. Some gel devices that you can give, keep the affected areas clean and dry, because if it is not clean and dry, what can happen? If it is like sweating all the time, and if you're not keeping it dry or clean, it can actually lead to some skin infections as well. So you have to be very careful of that. Use anti sprays, I mean the deodorants, antiperspirants that are for excessive sweating. Consider using absorbent material like sweating pads or clothing liners. Maintain a healthy weight and regular exercise routine to manage your symptoms, right? There are further management plans as well. To be honest, if you mention this much, that's more than enough. You don't need to go into too much of detailing. However, treatment options are there are oral medications as well to block the sweat glands. Botox injection can be given underarm for the sweating, and some like surgeries, ETS, and all that can be done. But I would say it is too much. You don't need to go into that. Mainly, you need to work on the lifestyle. You need to work on the stress. You need to work on the heat, for example, and your food, what you're eating, and maybe we can give you aluminum chloride. That is the main thing, right? And for these advanced treatment and all, if you have to go with, definitely it's not gonna given to you by the GP. We maybe refer you to the specialist as well. Is it lifelong? It can be a long-term condition, but we can manage or reduce the symptoms, and you will see over time it can improve. Why do I have it? The cause is often unknown, but maybe genetic, right? So sometime when we are doing this excessive, when we are having this excessive sweating, there might be a reason behind it. But I have taken your history. There is nothing sinister that I could find. So it can happen without any reason as well, and it can get worse when a person is having stress, when the person is having anxiety, when person is obese, when person is, I mean, having any of these things, right? So that is what we need to cover in this scenario. So that's your primary hyperhidrosis. Please try to find out if there is any reason behind it or not. That is really important. All right. Okay. Amyotrophic lateral sclerosis, motor neuron disease. You are referring to in GP surgery. Patient is Matthew, age 57. He has booked an appointment to see you. He was he was diagnosed 8 months ago with amyotrophic lateral sclerosis, which is a motor neuron disease. He has been following up every 3 months with the neurology team. So he's going to the referral every 3 months, and he's requesting for the medication named Riluzole. He's requesting for Riluzole. Talk to the patient, assess and address his concern. See, now, if you get these kinds of scenarios, it might be a bit difficult. For example, if I look at this scenario, motor neuron disease, I've got a bit of idea, right? Now, Riluzole, sometimes the thing what can happen is I'm not pretty sure what is this Riluzole. And if I got this scenario, I know in 8 minutes I'm going to struggle. I'm not going to get any of the thing from my patient. And if they ask me any question, I know I can't answer at all. So the thing is, when you get these kind of stations, you have been given a medication, Riluzole. Patient is requesting Riluzole. So if I don't know what Riluzole is, I can't stay in my scenario for 8 minutes. I'm going to struggle, isn't it? And my answer to my patient is, I don't know, I don't know, I don't know. That is what's going to happen, isn't it? So there is no harm if I open the BNF and have a look what this Riluzole is, right? So go into the cubicle, start your conversation. How can I help you? Doctor, I want the medicine Riluzole. Okay, so I can see you want the Riluzole, and I have seen your notes which says that you have been diagnosed with amyotrophic lateral sclerosis, and you are going for your review every 3 months to the specialist. and you want Riluzole. All right, perfect. Let me ask you some question and we'll see what best I can do for you. So what I did, I just acknowledged and I just said, these are the things that is already given to me in my notes. So I just acknowledged everything to my patient. Now, before you enter into this, before you jump into the scenario, what I would like you to do is tell the patient, let me have a look into my book and I'll get a bit more idea about this medication and I'll be able to help you out in a better way. Now, please open BNF and read a bit more about Riluzole. So you will be in a better position to answer the questions, right? So read what Riluzole is and what is the function of it, which patients we give it, are we supposed to give it or is it given by the specialist and all? What are the things we need to look for before we give Riluzole because it can affect your liver, your kidneys, your lungs. So just check all those things, right? And please keep in mind which page number you have seen. So if in case patient asks you a question, you still don't have the answer, the book is there, just check in the book and you can give the answer. What is the problem? See, unlike our country, in our country, what happened if you have a patient with you in your cubicle, in your clinic, and if you open the book in front of the in front of the patient, your patient is like, what kind of doctor you are, isn't it? But it's not like that here in our country, here in the UK. So the patient, they appreciate. I mean, if you want to have a look for anything, they don't bother about that. So it's like, okay, that's fine. I mean, if you want to have a look, that's okay, right? So if you get, not only for this scenario, in any scenario, if you get something like a medication which you don't have any idea about, so what you do, please open the BNF. Do not hesitate to open the BNF. You are not going to lose your marks if you open BNF, please, right? So I want the medication Riluzole. Again, don't deny, I'm not going to give you Riluzole because usually what happens is Riluzole is usually given by the specialist. So what you do, listen to the patient, build the rapport, try to understand what is the mindset of this patient, why is requesting for it. So just go into detailing. So I can see you want Riluzole and I can see from my notes you've been diagnosed with ALS and you've been going to the specialist every 3 months. Am I right? Yes. So let me ask you some questions to see what we can help you with. So ask the patient, what do you know about this ALS, right? So it's a basic counseling scenario. So what you need to know, what do you know about your condition, amyotrophic lateral sclerosis, right? So are you going to your doctors for the checkups, right? And are you attending all their visits and all? So you are following up with your specialist, that's fine. So you asking for Riluzole, from where you got to know about Riluzole? How much you know about it, right? Did you mention it to the specialist about Riluzole? Because you see, this patient is going every 3 months to the specialist. You can ask, did you speak to the specialist about this medication, Riluzole? And I'm sure this patient has spoken to the specialist as well. So you need to ask, what was their response? Why he didn't prescribe it to you? So you can ask all those questions, right? So what we need to do in the beginning, you need to ask what he knows about ALS, if he's going for all the reviews to the specialist or not. He wants a Riluzole. So he knows what is Riluzole or not, and from where he got to know about Riluzole. Did he mention about Riluzole to the specialist or not? So all those questions you can ask, and it's going to be very helpful in building the rapport as well. Now, patient is having ALS, so you need to ask some questions about ALS as well. I mean, if it is improving or if it is getting worse or if it is maintained properly or not. So ask some questions about ALS. So you can ask about if there is any weakness, any slurring of speech, any weak grip, muscle cramps, weight loss, all those questions you can ask for ALS, right? So that's really important. Then go for quick past personal and social history as well. Okay. Riluzole is the thing. Let's talk a bit about Riluzole. So Riluzole medication, it is prescribed by a specialist to help slow down the disease progression. So we have to see patient accordingly, we will decide whether I'm going to prescribe Riluzole or not. Because it can give you lots of other problems as well. Yes, we give it to some patients so that we can slow down the progression of this disease. But sometimes, if patient has got other underlying conditions, we may not be giving it to the patient as well. What I mean by that, let's have a look. Okay, Riluzole can extend survival and delays the need of breathing support. But what we have to do, we have to do the blood test, liver and kidney function and chest x-ray before starting the medication. It can affect your liver, it can affect your kidneys, and it can actually cause pulmonary fibrosis as well. So the thing is, if patient already have some lungs problem, so the specialist has to see benefits of giving these medications are there or not, or it's going to make things worse for my patient. So that is really important. So that's why the specialist has to do a lot of assessment before deciding if I'm going to give this or not, right? And obviously, regular checkups and all these things will be done to monitor the side effects. Side effects are pulmonary fibrosis and obviously the problem with the liver or kidneys as well. So that is something that we keep on doing. So that's why what we can do here is we can ask, I would like to do general physical exam vitals and neurological examination, obviously chest examination as well, to make sure the patient is not having anything of sort of this pulmonary fibrosis. We can go for chest x-ray and some routine liver kidney function test as well. Okay. So, as you know, Mr. Shoppy, that it's a motor neuron disease that affects your brain and nerves. It causes muscle weakness and it worsens over time. Yes, you're right. This medication, Riluzole, can be given to some patients and it actually can delay the progress. It can slow down the progress of this condition, but it's not given to everyone. We have to see the pros and cons, and it's usually prescribed by the specialist. So you are going to the specialist every 3 months, right? So what I can do, maybe I can write a reference letter and maybe they can have the next appointment early with you. And there you will be able to discuss about this medication with them, right? So that's something that you can mention. So what are the supportive care? Usually we give it to a patient who's having ALS. So occupational therapist, daily activities, the mobility and all, and the physiotherapies and speech and language therapy. It depends on the symptoms. Whatever the symptom the patient can have, accordingly, we will be able to offer the supportive care, right? And ongoing care is essential to manage symptoms and improve the quality of life. A team of specialists will support you throughout this journey. That's okay, right? So whenever patient is requesting for any medication, what you need to do is acknowledge it. And if you want to see from the BNF, see it, no problem at all. Get the understanding of the patient, what patient knows about ALS, what patient knows about Riluzole, from where he got to know about Riluzole, why he didn't, or did he mention about this medication to the specialist or not? If not, why you didn't, and we'll make an appointment so I can discuss it with him because it's usually prescribed by the specialist. Ask a couple of questions about ALS if the things are under control, if things are getting worse. Quick past personal history, and make sure you ask some questions and do some investigation to make sure you're looking after liver, kidney, and lungs, right? And that's it. And tell the patient about the management. All right, so that's what we have in ALS. All right. Okay, let's begin this one. Frontotemporal dementia. Your FY2 in GP surgery. Your patient is Kim White, age 65, has brought in the husband, Mr. Benedict White, age 69, who was diagnosed with frontotemporal dementia. Talk to her and address her concern. So the thing is, you're talking to the wife. Husband is a diagnosed case of frontotemporal dementia, and wife has got some concern. All right, so I'll discuss about it. Before that, let's talk a bit about what actually frontotemporal dementia is. Frontotemporal dementia is a condition that affects frontal and the temporal lobe, as the name suggests, frontotemporal. Frontal, which helps in talking, temporal, which helps in listening, right? Frontal is here, so you talk from the front, and temporal is on the side, which helps in listening. Yeah. So, condition that affects frontal and temporal lobes of the brain, which are responsible for your behavior, your emotions, and sometimes language, right? So, the symptoms of frontotemporal dementia. The thing is, this station is not about diagnosing frontotemporal dementia. I'm just telling you a bit about frontotemporal dementia, but this station is about the wife. It's about something else. It's about something else. All right. So, symptoms of frontotemporal dementia. So, changes in the behavior, like sometimes you'll see patient is acting impulsively, not caring about their hygiene. That's very important, and that's the concern of our patient as well. The lady, she has got that concern. I'll come to it. Eating too much or feeling unmotivated, trouble with the speech, talking slowly, using the wrong words or mixing up sentences, difficulty with thinking, getting distracted, right? And they are struggling to stay organized. Memory problem usually happens later, unlike in the conditions of Alzheimer's, but it can happen, but that's going to be the later thing. What are the causes? It happens when abnormal proteins build up in the brain, damaging cells and stopping them from working properly. That's the main reason. Usually we do full blood count, we have to do the scans. Sometimes we do LP as well, just to make sure we are ruling out Alzheimer's, right? And genetic testing can also be done. Treatment includes the medicine for the behavior, therapies for the movements, communication, memory, cafes for support, and support groups and all, and OTPT therapies and all. So that is what we have in frontotemporal dementia. All right. But have a look at the scenario, what the scenario is. I know I was quick with frontotemporal dementia because that's not our scenario. Now have a look. How can I help you? This patient, wife is saying, I feel low. This is actually a scenario of low mood the lady has got because of her husband, who is a diagnosed case of frontotemporal dementia. All right. So I feel, look, could you please tell me a bit more about it? Because the thing is, my husband is a diagnosed case of frontotemporal dementia. It's difficult to handle him, and I'm getting overwhelmed with it. Okay, so now what you're gonna do? You have to ask a few questions about the husband, and obviously I have to ask question about my patient as well. Okay, so you can ask when he was diagnosed. Yeah, what kind of treatment he has been given, what do you know about frontotemporal dementia, because if she doesn't know, we can give a bit more information to her, like what is the reason behind it and what are the symptoms and all that are expected in these kind of things. So if she already knew it beforehand, she will be able to cope up with the situation a bit better, right? Right? Yes, it's a carer burnout. That's what you can say. Yeah. So when was you diagnosed, and what's your understanding about the diagnosis? How he has been managed? What kind of support he is getting? And are you the only carer if we have got other carers or not? So these are things that you can ask. Now ask a bit more about this patient. She is feeling low, right? So we have to do, I would say, a quick depression screening here as well. So what does it mean? She's feeling low, so how it has impacted you in general. So what kind of history is very important in these kind of cases? Psychosocial history is the most important history, right? And ask about her mood, obviously. So you can ask her to score the mood as well. Then I want you to ask anhedonia. Then what is going to be more important? Her sleeping, her eating, that's very important. Examiner is looking for this thing as well, harming themselves, so suicide. That's really important, right? So if you have tried harming yourself or you tried harming others, that is the main thing that you need to look for, right? And also ask in psychosocial history if she's a working woman or not, and if she's working, who is looking after the husband, if she's the only carer or not, right? So all those questions I want you to ask a bit more in detailing, right? Then I would like to go for general physical and check your vitals and all. I'm checking this lady, right? So she's the patient here. The management is what? So management is simply, I can say that you are overwhelmed in looking after your husband, and feeling low is very common when your loved ones have been diagnosed with such a condition. However, the supports are available for you and for your husband as well, right? So we have already asked her what kind of support and help you're getting from our side. And if you feel it's not enough, so we may be able to discuss more management plans as well. Yeah. So what we have got for you is emotional help, so counseling and support groups. We have got practical support. It's a carer assessment, respite care. What is this respite care? It's a temporary care option to give her time to rest and recharge. Right. So we have got respite care. So what they can do is it's a what happen is okay, so I'll come to it. So financial aid like care allowances, education about workshop and advice on managing dementia, local service memory clinics and dementia cafes. So what happened in this respite care? So you will be able to leave your dear ones there, and they will be looked after by the team. Meanwhile, what's going to happen temporarily basis, you will have some time off, right? So you will be able to relax and you will be able to recharge yourself. That is the main thing here. It's important to monitor your mood and how you're coping. If things are getting harder and if you feel worse, please do not hesitate to reach out to us. We'll arrange the regular follow-ups and do whatever is required. Also, what I can do for you, I can book an appointment. I mean, you can book an appointment maybe for your husband as well, and you can ask for some support for him as well if you are not satisfied with the help that we are giving. Okay, so in this case, what you have to do? Again, this patient is saying, I'm feeling low. So you have to take history for both. You have to take the history for her, obviously. She's feeling low. Ask about her mood, scoring of mood, eating, sleeping, anhedonia, suicide. If she is able to concentrate on things, if she's a working woman or not, whom she's living, if she's the only carer, right? Then ask her about her husband as well. When he was diagnosed, how things are going at home. Are you able to manage on your own? Do you need some more help from our side? And what is the main thing that is bothering you? And sometimes you see this lady is saying the thing is not taking care about hygiene. That is the main concern she has got as well, and I don't know why it's happening with him. Then you can explain it can happen when somebody is diagnosed with frontotemporal dementia. It can happen. So the management is just the counseling and the support services. That is something that you need to provide, right? So even if you not use these things and carer assessment, respite care, you can mention that. So it's a temporary care option to give her time so that she can rest and she will be re-energized to do her things in a better way. Okay, so that's what we can say. So you have to see the station is a diagnosed case. So to be honest, when this station came, I don't think candidates were struggling. They were able to manage it in an easy way. Okay, all right. So that's your frontal temporal dementia. Okay. The next one is Huntington's disease. Huntington's. Your FY2 in GP. Patient is Mrs. White, age 27. She's come to you because she's worried about inheriting Huntington's disease. Her mother has been diagnosed with this, and what you need to do is talk to her and address her concern. Okay, so that is what his are concerned. She's worried about Huntington's. So, what do we know about Huntington's? So, I've put a mnemonic actually for you guys. It was available online. So, Huntington's, what happens in it? Huntington's, this is a mnemonic. H is hyperkinetic move. So, you'll see the patient might have chorea, tics. So, these kind of movements, involuntary movements your patient might have, right? U, use unsteady gait. So, they will have the problem with the gait, problem with the coordination. Then they might have neuropsychiatric problems like depression. So what you can do, you can ask questions for depression as well. Again, the same thing I'm going to repeat. So mood, you can ask for anhedonia, you can ask for sleeping, you can ask for eating, you can ask for suicide as well. So all those questions you can ask. Trigger. So what are the trigger factors? The thing is Huntington's, you are, if your mother has it, you are having 50% of chances having it because of its nature. It is autosomal dominant. I'll come to it. So what are the trigger factors? The trigger factor can be stress, right? And the age your mother got this Huntington's, it's not like you are also gonna get in the same age. So it can be different for you as well. So if you are having a work which is like too much of stress and all, so you may get it early as well. So that's how it is. Yeah. Impaired cognition, so they may have memory loss as well. They might have an nystagmus, abnormal eye movements as well. G, it is a genetic, it is autosomal dominant. T is 30 means it happens usually in around 30 years, 30 to 50 years, that's what you can say. Over time, it can get worse. It can lead to weight loss, and the main thing is dysphagia. So that's why you will see in the advanced stages of Huntington's, the patient they will be needing too much of support in terms of eating, in terms of tube and all, because in later stages, over time, it's going to get worse and it's going to cause severe dysphagia as well, right? And it's no cure, but we can manage the symptoms over time. That is the main thing. So this is, if you know this Huntington, you will be able to manage this scenario. Okay, so let's have a look what exactly they are expecting from us in this particular scenario. So you are in GP, Tracy is 27, has come to you because she's worried about inheriting Huntington's because her mother is a diagnosed case of it. Okay, so how can I help you? I'm worried I might inherit Huntington's because my mother has it. Okay, so what you need to know now here is, I'm sorry to hear about your mother, how your mother is doing at the moment, and if she's okay or not, and at what age she was diagnosed, because that is really important for us, right? So now what we are doing, we're checking her understanding. How much do you know about Huntington's? Tell me more about your mother's diagnosis, when she was diagnosed, how is she being looked after, what kind of treatment is she getting, and how is she now? So that is the thing. These are the things you need to ask, right? So what do you know about it? And what is your mother's status when she was diagnosed, which symptoms she had, what kind of treatment she's getting, is she okay or not? So show some empathy for her as well. Now, what you need to do, she's 27, and we know it can happen in somebody somewhere at like 30 years. After 30 years and all, it can happen. And if the mother has Huntington's, there are high chances she might get it as well, isn't it? Because of its nature, isn't it? Because it is autosomal dominant. Yeah. So, for example, you can put it in this way. So we have got, say, father and the mother. Mother has got Huntington's. Yeah. So what's going to happen? This is a normal child. This can have Huntington's. So this is a normal child, and this can have Huntington's. So this is father, father, mother, mother. Mother has Huntington's, right? It's autosomal dominant. So there are 50% of chances that daughter, she can get Huntington's as well. That is really important. Her concern is valid. Her concern is valid. So even if you get a pen and paper, you can explain it in this way as well, right? So now what you can do is you can ask her some questions as well about Huntington's. So which questions you can ask? These questions you can ask. If they have got any involuntary movements, if they have got problem with the gait in walking, any problem with the coordination, how's her mood, sleeping, eating, suicide, stressed, what kind of work she's doing, if she's okay with her memory or not, any problem with the eyes and all. Ask those questions, the symptoms you can ask, right? So this is what I've tried asking here. If you've got any involuntary movement, change in your coordination, any difficulty with the memory, mood, you can ask all those things, right? Okay. So now she's worried that she might get Huntington's, but we have to be very careful. We need to do a bit of counseling for her kids as well. If she's in relationship, if she is having any kid, or she is planning to have kids or not. So we need to think about that as well. So that's what I want you to do is whom you are living with. If the partners are there, ask for children. That is very, very important. If there is a partner, if you have got kids or if you're planning to have kids, that's one. Another thing, if you have got any brother or sister from the same mother, I mean, if you've got any siblings. Because if the mother have Huntington's, there are 50% of chances the children will get Huntington's as well. So that's why you need to ask if there are any siblings and if you are having any kids or not. So this is very, 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 very important thing. Okay, so what are we asking? We're asking about Huntington's, about the mother, what's happening with the mother, how is she now, which symptoms she has got, what do you know about Huntington's, if you have got any symptoms of Huntington's or not, who's there in your family, are you in a relationship, are you like any kids if you're having, or if you have got any siblings or not, right? Quick past personal history, because here you need to take proper psychosocial history as well, including stress, including job, what kind of job you are doing. Yeah. From which vitals, do a general physical examination, it's a blood test, and mainly for genetic testing. That's the main thing. Huntington disease, it's a genetic condition, autosomal dominant, and if a parent has it, there is a 50% chance of inheriting the gene. However, not everyone with this gene develops symptoms at the same age or in the same way. So if the mother has got different symptoms, maybe the daughter can have different symptoms. Maybe mother had got it at the age of 40, the daughter can have it at the age of 50, can be there at the age of 30 as well. That is the main thing. Okay. So for genetic testing, refer to the genetic counseling to explain the process and support your decision. Regular checkups for physical and emotional support. Resources point to help with understand the condition better. Preventing inheritance options include genetic counseling, pre-implantation genetic diagnosis during IVF, adoption. Discuss it with your healthcare provider. Meaning, if she's planning to have kids, what we can do, we can refer her for genetic counseling, and they will be able to counsel this patient for more detailing, right? In terms of treatment, if you have to talk about, there is no cure, but the treatment can manage the symptoms and improve the quality of life. So medicines like antidepressants, mood stabilizer, or treatment for the involuntary movements. So the treatment is going to depend on which symptom the patient has got, right? For the daily task, use ramps, stair lift, grab rails, electrical aids, occupational therapy offers. Why? Because the problem is going to be with the coordination as well. So that's why. Eating and communication, not early, but in the later part of the later stages of this illness, it is going to give you dysphagia as well. So that's why you'll be needing the support from for eating as well, feeding tubes and all. And movement stay active, walking aids with therapy and all that is quite helpful. See, the scenario is not about talking about the treatment. I have written the treatment here, but the scenario in the scenario, you're not supposed to talk about the treatment of Huntington's, right? Because she's not having Huntington's at the moment. And even if you ask the questions to her about the symptoms of Huntington's, she's not having it. But she's worried, can I get it? So the answer is yes, you can get it. And there are high chances because of your mom having it, right? So 50% chances. We can explain that. But then you will do the counseling as well that it is not like treatable. We can't like cure, but the treatment is like we can manage the symptoms. We can improve the quality of life as well. And then you talk to her about the future as well. If she's planning to have kids, for that, what we can do, we can actually arrange a genetic counseling so the counselor can speak to her, can explain her about the pros and cons and what are the investigations and all genetic counseling we can offer her, we can offer. Right? And ask about if she has got any brother, sister or not. So these are the things that you need to cover. Okay. So that's the main thing. So treatment I have written here, but the station is not about the treatment. The station is about addressing her concerns about Huntington's. Right. So that's the main thing. And please remember this Huntington as well. Hyperkinetic moves, unsteady gait, neuropsychiatric problem like depression, triggers is like stress, impaired cognition, memory loss, nystagmus, abnormal eye movements. It is on genetic autosomal dominant. T30 to 50 years, that's the main age group. Over time, it gets worse, can lead to weight loss, can lead to dysphagia. That's the main thing. And there is no cure, but we can manage the symptoms. Right? So that's what we have got in Huntington's disease. All right. So the next one we have got is general anxiety disorder. Okay. So your FY2 in surgery, patient is a final year medical student, has come to you because of feeling anxious. Talk to her, address her concern. That's the main thing. So general anxiety disorder. I have a mnemonic for it, watchers. So how you gonna differentiate it from depression? Obviously, we can ask questions about depression as well. Depression is mainly, you will see low mood. This is not low, it's mainly of anxiety, more of anxiety in general anxiety disorder. So here you will see, you will feel low mood. Patient will have anhedonia. That is the main thing that you usually see. And you have got lack of concentration as well. So these are the things that you will see, right? So mainly low symptoms. Anxiety is more of anxiety, anxious feeling, not low. They're not low in general anxiety disorder. Before you say that you may have general anxiety disorder, we need to have a bit more history, long history. Usually a few months history you need, 6 months maybe history. It's a bit chronic history. For depression, if a patient is feeling low, and if I've got history of even 2 weeks, more than 2 weeks, I might be able to diagnose the patient with depression. Why I'm explaining it here? See, one of the main differential here, you have to go with this depression as well. But there is a slight difference between what is GAD and what is depression. Depression mainly depressed symptom, low mood, not able to concentrate, not enjoying things. That's what you get. And the histories may be very much like, say, 2 weeks, 3 weeks, so we can diagnose depression. But for general anxiety disorder, you need more time. You need like 6 months history. Then only you might say you may have a condition called general anxiety disorder. The treatment is more or less the same, but we need to get the diagnosis. So these patients, they're worried about something. They feel they have anxiety when they have to do some particular thing. And because of this tension, they just feel the whole body, the muscles are stiff, tension, headache, band-like headache, neck stiffness, everything they get. They have problem in concentration as well. Their threshold is very less. I mean, threshold in terms of the irritability threshold is very poor. They get very, they get irritated very easily. They don't have energy. They just feel malaise, tired. right? Restlessness and sleep problem is there. So you see lots of things. A lack of concentration, sleep problem is there in depression as well. But depression mainly comes with low symptoms. That is something that I want to clarify here. So what happens? What happens here? How can I help you? Doctor, I feel anxious and I get tremors when I try to do the procedures in the hospital. So when I try doing some procedure, I feel anxious. That's the main thing. It's not feeling low, feeling anxious. How long you been having? It's been happening for past few months. Sometimes this patient is giving the history for 7, 8 months as well. Sometimes giving the history for 1 year as well. Then how it has affected your daily life. I feel less confident at work and I've got trouble in focusing as well. Over the past few weeks, how often you felt anxious? Quite often, especially when I'm doing a procedure. Do you find it difficult to control your thoughts? Yes, I can't stop thinking about the procedure and it makes me more nervous. Have you experienced any physical symptom like restlessness, fatigue, trouble sleeping due to anxiety? Yes, I've been tired a lot, sometimes can't sleep at night. So with this question, obviously I've asked many questions here and I would like you to ask one question at a time. That would be much, much better, right? And obviously, you can ask the problem with the concentration as well. That is the main thing, right? And now, in this kind of station, what you need to do, you need to rule out some things as well. So this patient is feeling tired. This patient is feeling anxious as well. This patient is a female patient. So what comes in your mind? What are the medical things that comes in your mind? That is, one is thyroid. That is the main thing. Because of female, young female, I definitely have to rule out thyroid. So ask questions about thyroid. Ask questions about diabetes as well. And in the later part of the station, there's no harm if you would like to check the blood sugar of this patient or you would like to check for thyroid function test as well, right? Quick depression screening. How's your mood? If you're enjoying things you used to enjoy before, sleeping, eating, we have already asked. Ask this question, ask this patient about the suicide. I mean, if you feel, when sometimes some people feel low, they just try harming themselves or try harming others. Have you ever thought of doing the same? No, doctor, this is not something there in my mind. So all these things you can cover. All right. So, and then, as I said, general physical vitals, and you can go for some investigation, and that includes the random blood sugar and thyroid function test. Okay. So, based on what you told me, you're experiencing generalized anxiety disorder, which is quite common, especially high stress environment like the medical school. It is a condition where excessive worry about various aspects can become overwhelming. It's not a weakness, and there are the effective ways we can manage it. So treatment, as I said, whether it is GAD, whether it is depression, the treatment is the same. It is CBT. It is one of the most effective treatment for anxiety. It helps to understand and manage your these anxiety things, right? And if need to, we can. So what we can do, I can refer you to the therapist, and they'll be able to manage it in a better way. Now, depression, when we talk about what is the treatment of depression, CBT plus to manage depression, what we do, we have to have a very good lifestyle as well. So we always say if a patient has got depression and if he's smoking, you need to talk about no smoking. If they're drinking alcohol, no alcohol. And not a good diet, so encourage them to have good diet. And you encourage the patient to be physically active. You know, if a patient is having mild depression, for example, and if they are physically active, they started going for regular walks and gym and all. They started feeling better actually. Same thing here as well. So what you need to do is you need to talk more on the lifestyle thing. Regular exercises, practice relaxation techniques, yoga, healthy diet, regular sleep, and limit your caffeine and alcohol intake. Same thing. So what you need to do here in this scenario, you need to take detailed lifestyle history about smoking, alcohol, diet, physical activity, whatever negative you get, you just mention it here. Right? So that's the main thing. Or we can go with CBT. That's it. Treatment for GAD, treatment of depression is same only, right? If symptoms persist or worsen, we can consider giving the medication as well. What medication? Antidepressants. We will first explore non-pharmacological option. I'll arrange a follow-up appointment to monitor your progress and adjust the plan if needed. So what is the first thing you're doing? Is a lifestyle management and CBT. So what's the difference between GAD and depression? Both are kind of a lot of symptoms are same, overlapping. Depression, 2 weeks history. For GAD, I need long history, maybe 6 months history. Depression, more of low symptoms. Here is more of anxious anxiety because of some work and all. So that is a slight difference between these two things. Management is kind of same if you see in general anxiety disorder or GAD. All right. Okay, so let's go with the next one. Hyperemesis gravidarum. You're FY2 in OBGY, and your patient is 27, presented with sickness and vomiting, right? She's 12 weeks pregnant. Talk to her, assess, and address her concern. All right. The thing is, in the first trimester, having nausea, vomiting is not something unusual, right? And that's why you will see a lot of women. I mean, they're pregnant, but in first trimester, a lot of women you will see they actually lose weight. In second, third, obviously you gain weight, but when they have got severe nausea, vomiting, they sometimes lose weight as well. And if vomiting sickness is too bad, I mean, they're not able to take anything, whatever they're taking is just coming out, and patient might be dehydrated and all. In those cases, we may have to admit and manage these patients. So if it is excess of vomiting and all in pregnancy, that's what we say hyperemesis gravidarum. So how can I help you? The patient is saying, I'm feeling sick and I've vomited a few times. Okay, so what do you do? Tell me more about it. Yeah, that's what you do. I mean, when did it start? Is there anything makes it worse? Is there anything that makes it better? And how often you get it? How many times in a day you get it? So all these questions are just doing a bit of OD para, I would say, right? So that's what you can do, right? And anytime, any scenario, if you see patient is having vomiting or patient is having diarrhea, what we do? We need to rule out dehydration. Keep your basics clear. The exam is easy. So what we do, we ask about, do you feel thirsty? If the urine is dark, like dehydration, right? Any mouth or lips dry. So these are questions for dehydration that you can ask, right? Now, patient is pregnant. So what you can do, you can bring that also in the picture that I can see from the notes that you're 12 weeks pregnant. How's everything? Is everything all right? Other than your nausea, vomiting, right? Have you attended all your antenatal visits? Whether there was any problem in the last visit or not? So all those questions, right? And now what I will ask, I'll ask for any tummy pain because that's important, any breast tenderness, any fever, any loose stool, any trauma, any headache, any weight loss due to excessive vomiting. So there are some associated symptoms of excessive vomiting. Because of excessive vomiting, patient can have tummy pain as well. Fever and all is very important. And obviously, I will ask for any weight loss because of excessive vomiting. And that's why I said, I mean, mostly half of the women they'll come to you and complaining of I'm losing weight in my pregnancy, mainly in the first trimester, right? So what else we can do is as she's vomiting and also we can just quickly take past personal history as well, right? So any medical condition in the past, any drugs and all if she's taking supplements, that's okay. Any other thing if she's taking or not. So we have to be very careful with, right? And we just ask a bit about her pregnancy as well, right? Then whom she's living with, because we have to have a proper psychosocial history as well. As she's vomiting too much, so we have to think twice. Am I gonna keep her in the hospital? I'm gonna send her home. If she's going into dehydration, obviously I have to keep her home or keep her in the hospital for IV fluids and all. But even if I'm thinking of discharging her later, I have to see if she has got a support at home or not. So that's really important, yeah. So I'm going to do the vital general physical examination and urine analysis as well. Why urine analysis? Because if you're not able to eat and whatever you're eating, you're just vomiting it out just to make sure we don't have any urine ketones and all, right? Sometimes the examiner might say that ketones are positive. That's really, really important. And it's a matter of worry. So what you're going to do is you'll explain that we have done the investigations and what we think is you've got nausea, vomiting, which is kind of common in the early part of the pregnancy in first trimester. But when it is in excess, it can lead to a thing, or the name of the condition is hyperemesis gravidarum. That can make you feel very unwell. It's not going to harm your baby because that question is going to come from the patient side. Is it going to create any problem with my baby? The answer is no, it's not going to create any problem with your baby. So we'll continue to monitor you and manage your symptoms with the medication, and it's safe. It is safe. So what is the management? So you see, ketones are positive. Plus, this patient is not able to take anything, cannot tolerate anything. So, what you need to do, you'll admit and give IV fluids. Encourage the patient to go with the small and frequent meals. That's really important. Small and frequent meals. That's what you have to do. Eat every half an hour, every 1 hour, but eat in a very less amount. That's the main thing, right? So vitamin B6, thiamine, that's really important. And that's quite helpful in pregnant women. Usually they try not to give any medication, but the guideline says it's okay. First line, pyridoxine, vitamin B6, it is quite helpful, and that's given to the patients. We can give antihistaminics as well, but this first line treatment, this vitamin B6 is quite helpful. All right. It's severe dehydration, weight loss, uh, more than 5% failure to outmatch treatment, psychological support for emotional well-being, a referral to a specialist care if needed. That's fine. See, whenever these patients, when they're pregnant and they're having got severe nausea, vomiting, are they going to go to the GP? Not really. So they're going to go to the hospital, A&E. So I know I've written OBGYN here. So what is going to happen? Patient is going to come to A&E, but then we have got separate department for OBGYN and pediatrics. So rest of the cases, whether it is medicine, surgery and all, we manage in the A&E. But if it's a gynae case, we send to the OBGYN A&E. If it's pediatric case, we send them to the pediatrics A&E because then specialists will be able to see the patient then and there. That's how it is. So the station can be you are working in A&E, the station can be you are working in OBGYN, which is absolutely okay. So admit this patient as she is having severe nausea, vomiting, give IV fluids, encourage her for small and frequent meals, and we can give her vitamin B6. That's quite helpful. Right? She's gonna ask you some question. Is gonna harm my baby? Not really. We can manage it. And the medication that you're giving, is it safe for my baby? Yes, it is absolutely safe. I know you are worried, and you're rightly so. And the thing is, yes, in the pregnancy we don't give much of medication, because it can affect the babies, right? But the thing is, there are medications which are safe to be given in pregnancy, and this is one of them. So you don't need to worry about causing any problem to your baby. So rest reassured, right? So that's what we can do. All right. So that's your vomiting, hyperemesis gravidarum. Yeah. Okay. So carpimazole, agranulocytosis. You are FY2 in A&E. Let's make it A&E. Your patient is Mrs. Grace, age 40. She's come to you with sore throat. She started on carbimazole 3 weeks ago for her hyperthyroid. Talk to her, assess her, address her concern. See, carbimazole, it's very tricky medication, right? So you have to be very careful because we know the main thing about this carbimazole that it can lead to a granulocytosis, right? So that's the main thing. Yeah. So we need to work on it. And if it is a granulocytosis, we have to stop carbimazole quickly. Yeah. So what we do, how can I help you, doctor? I'm having this pain in my throat. Tell me more about it. I'll do a bit of Odipara. And I've been given this information that 3 weeks ago we started the patient on carbimazole. So that is very important history for me, right? So do a bit of Otipara about sore throat. When you're having it, is it only the first time? Did you get it previously as well? Anything makes it worse? Anything makes it better? All those things. If you've got anything else other than your sore throat, right? When this is sore throat, carbimazole side effect, agranulocytosis is there in my head. So I need to ask questions if there's any fever, chills. Usually patient is saying, yes, I'm having fever and chills. And dizziness I can ask, right? Now I will ask other problems that a patient can have when they have got a granulocytosis. For example, like any side effect like joint pain, they can have swelling of the face and lips, skin reaction, changes with the color of urine and stool, any tummy pain. See, the severe side effects of carbimazole can lead to acute pancreatitis as well, which in turn lead to tummy pain and can lead to the problem with the color of urine and stool as well. So that's why these questions we need to ask. Now, also, I would like you to ask some questions about thyroid as well. You can ask some questions about hypothyroidism and hyperthyroidism as well. Just a couple of questions. See, anytime when a patient is on medication for thyroid, whether it is for hyperthyroid or hypothyroid, whether it is levothyroxine or carbimazole propylthiouracil, you and patient has come for the follow-up and all. You need to ask question for both. You have to ask question for hypo or hyper as well, because patient is on medication, it might be too less or it might be too much. So that's why. So any weight change, any diarrhea, constipation, all those questions that you can ask. Female patient we have got, so you can ask a bit about the LMP as well, right? That's very, very, very important, right? So these are the questions. So what are we asking? We are asking about carbimazole. We are asking about the side effects of carbimazole. We are asking about carbimazole side effects. Also carbimazole compliance as well. That's very important. So if there is any side effect or if the patient is compliant with it, right? So how can I help you? I've got pain in my throat. Tell me more about it. I'll just elaborate it. And anything else? No, doctor. So as I can see from the notes, you've been taking carbimazole. Are you taking it regularly? Yes. Are you taking it as prescribed? Yes. Any missed dose? No. Okay. Fine. So I want to know about the carbimazole, if you've got any side effects of it. Like, what do you mean, doctor? So any joint pain, any tummy pain, any changes in your stool color, your urine color, any skin changes? And then I'll ask some question for hypothyroidism as well. Any weight loss, any weight gain, or any weight change? That is quite better. And any diarrhea, any constipation, any problem with, like, if you feel cold when others are feeling okay, if you feel hot when others are okay, right? And then as you have female patient, ask questions about her menstrual period as well. So that will complete your history, right? I would like to do general physical examination, vitals, and do the neck examination, and we can do mention ENT examination as well. Why? The presenting complaint is sore throat. That's why. I would like to do the routine blood test and obviously thyroid function test. Routine blood test, why? To find out granulocytosis, right? And thyroid function test. Makes sense. So exam exit the temperature is high. Temperature is high and you will have a few symptoms suggestive of granulocytosis as well in the history. So what we have to do, that it looks like you may have got this condition, granulocytosis. Carbimazole can lower down the number of white blood cell, WBC, and WBCs are crucial for fighting infections. Your white blood cell count may have dropped, making you more vulnerable for infection, and that's why you're having this condition, that is sore throat. And granulocytosis occurs when there is a significant reduction in the white blood cell, that is, increases the risk of infection. So that is a bit of counseling you can do. Now, what is the management? Management is, first of all, stop carbimazole. That's the main thing. So you stop carbimazole, and then maybe what we can do, we can start the patient on propylthiouracil. PTU, propylthiouracil. So that's what we can start the patient on. Admit the patient, right? And temperature is high as well. We are sending for this routine blood test as well. Wait for the report. You may have low WBC count as well. So antibiotics, that's the main thing. And supportive care, monitoring and management of any infection or complications. And blood test. So we keep on doing a regular blood test to see if the WBC count is improving or not. Yeah, and then we'll be involving the specialist as well so that we can manage the patient accordingly. Right? So that's what we have to do in this scenario. There are quite many scenario in thyroid. So we always have to be very, very careful here. So, and anytime if you see patient is taking any medication for thyroid, whether it is hyper or hypo, you have to ask questions for both, for hypothyroidism and hyperthyroidism. That's number one. Number two, patient is on carbimazole. Check the compliance if the patient is taking it properly or not. Then check the side effects if patient has got the side effects or not. Right? And LMP and all you can cover. And also, I mean, this is an emergency granulocytosis, but otherwise, we can talk about the pregnancy part as well, because we know even in pregnancy we don't give carbimazole, we give PTU. But I think the patient was started on this medication 3 weeks ago only, so I'm sure the doctor must have spoken about it. We can talk about this part now as well, but I think more important is granulocytosis. More important is the treatment of this infection rather than talking about pregnancy and all those things, right? So it depends. I mean, what kind of scenario you get, so just go accordingly. So discontinue carbimazole and admit and antibiotics and keep repeating these blood tests for full blood count, mainly to see granulocytosis. That is the main thing that you have to do. And please do not forget to give the warning signs and all to these patients. All right, so that's what we have got in granulocytosis. That's by carbimazole. Okay. Now, the next is lithium toxicity. So you are FY2, you're FY2 in A&E. Okay. Patient is Jordan, age 70, has been brought in by his son to the hospital with tremors and difficulty in coordination. Okay. He has been on lithium for the bipolar disorder. Talk to the son and address his concern. Okay, fine. So now what you have, how can I help you? My dad is having tremors and having trouble in walking as well. So you may have a scenario where you may have a station where you will see the patient is giving you 2, 3 symptoms in one go. So obviously, if there are many symptoms, I can ask which symptom is bothering you the most. That is what I can do. That's number one. And but if there are two symptoms only, obviously you can have two main symptoms. So I will elaborate them one by one. Now, how can I help you? My dad is having tremors and trouble walking. I know a lot of us, what we do, we ask the patient, could you please tell me more? Be a bit specific. Tell me more about his tremors. Let's elaborate the tremor first. Once you're done with the elaboration of tremors, then you say, okay, so you also mentioned about trouble walking. Tell me more about it. So this is much better way of elaboration of the presenting complaint rather than just saying, tell me more. As a patient, I'm like, tell me more about tremor or about trouble walking or about both. I'm not feeling very comfortable as a patient. Right? So as a doctor, make sure you ask very much specifically. Okay. So I would say, tell me more about the tremors. Like for how long he's having it, is there anything makes it worse, anything makes it better, is it continuously there, is it comes and goes, right? So all those things I can ask, right? Then trouble walking. So I can ask about that as well. Trouble walking for how long? Anything makes it worse or better? Is it like when he stand up all of a sudden? Is that when he's getting the trouble with walking, or is it every time it's there? Any weakness, any slurred speech, any unsteadiness, gait problem? If he had a fall in the last few days or not? So all those questions I'll ask. So I'll elaborate tremors. I'll elaborate this trouble walking as well. So I'll elaborate the presenting complaint nicely. Fine. Another thing I've been given in the question, that patient is on lithium for bipolar disorder. So I can see the notes that your father has been diagnosed with bipolar disorder and is taking lithium. Yes. Now check the compliance, if he's taking it properly or not. So is he taking it regularly as prescribed? That is main thing. Regularly as prescribed. By any chance, any missed dose or not? And if he's going for regular blood checks or not? See, lithium is not a straightforward medication. It has got a lot of problems with it, right? So we have to check the blood levels. We have to have regular blood level checks as well for lithium. So ask if we have done all those things or not. All right. Anytime, whenever the patient is on any medication, we check the compliance, and then what we check? We check if there is any side effects or not because of this medication. So I will ask the patient if they have got any nausea, vomiting, any diarrhea, excessive thirst, or polyuria, any headache, any blurring of vision, right? So all those things. These are the side effects of lithium. Now, patient is taking it for what? For bipolar. So how's your mood? How's your mood? Anxious, irritable? Ask a couple of questions for that as well. Right? So it's easy. So what we are doing, to be honest, question is telling you everything. First thing I did elaborate about tremors. Second, I did elaborate about difficulty in coordination. Third, I just checked the patient compliance about lithium. Fourth, I did check if patient is having side effects of lithium. Next, I just checked if the patient bipolar disorder, patient is having any more symptoms for it or not. That's pretty easy, right? So quick past personal history, that is what you can do. Sometimes the patient says that my father is diagnosed case of hypertension for last 10 years. Okay, so which medication is taking? Is he taking it regularly as prescribed or not? And if it is well controlled or not, right? So all those things you need to ask. Okay, I'm gonna check the vitals, general physical examination, and do neurological examination, doing some blood test, and lithium levels you need to check. That is the main thing. And then we'll say, like, what we're suspecting is the symptoms that you are mentioning. It could be because of high levels of lithium in the body. So this is what we can suspect. So now what we have to do, we are in which department? A&E. So definitely you will keep the patient in the hospital. And what is the treatment? Number one is discontinue lithium. That's the one thing. When I'm discontinuing lithium, I have to involve the psychiatrist as well, right? So you have to have the specialist for it, because you're stopping lithium. So patient bipolar disorder also we have to manage. So the psychiatrist will come and they will be able to see what I can manage. Okay. Uh, IV fluids, that's what we can give it to the patient. Gastric lavage is not like done routinely, but for example, patient is having bipolar disorder and they might have taken too much of lithium in one go. In that case, maybe gastric lavage or hemodialysis can be done as well. Mainly the treatment would be discontinue lithium and go for IV fluids. It depends on the symptoms. If the symptoms are mild or severe symptoms, mild, we might be going for stopping lithium and IV fluid, it should be okay. But if patient has taken recently a high dose of lithium, maybe we have to go for gastric lavage and hemodialysis as well. And regular blood monitoring, that is what you have to do. That is the treatment plan. But there is something that you need to suggest to the patient or the son here, that how we can prevent it from happening in the future. So prevention of lithium toxicity. Number one, make sure you attend your scheduled blood test. Do not miss anything. So once you're done with the blood test, if you need to make any changes in the medications and all, the dosage and all, we can do that. Gradually reduce salt intake. That is really important. So what happened is, when somebody diagnosed with some medical problem, from the next day they feel like I should be having all healthy things in my diet and everything. So you will see a lot of patients, they will all of a sudden will drop their sugar intake, will drop their salt intake. So that can happen. But we tell these patients, so you have to be very careful. Gradually reduce the salt intake. Why? This is very important. Low sodium can increase lithium level in your body. So that's very important. Yeah. Make sure you stay hydrated, because if you're not having enough water, that can be a reason of lithium toxicity. That's why the treatment here is IV fluids only. Yeah. So stay hydrated, especially during exercise and hot weather. Limit alcohol, avoid dehydration. In hot condition, inform doctors, pharmacists about lithium before you take any new medications. So there's some general advices and something that you can do to prevent this lithium toxicity from happening. Right. So that's really, really, really important. So lithium toxicity, I think the history is going to be pretty easy. Elaborate your presenting complaint, check the compliance, check the side effect of the medication, ask a couple of questions about bipolar disorder, and that's it. That is it. So that's what we have got in a scenario of lithium toxicity. All right. Okay, the next one. Endometritis. Endometritis. The thing is, it is an infection of the uterus, the womb lining, and there can be a lot of reason for endometritis. Even pelvic inflammatory disease, that is one of the thing for endometritis only. But here I'm looking for postpartum endometritis. What is it? Have a look. So you are in A&E, or sometimes they might say A&E, OBGY. Yeah. Your patient is a female patient, obviously, yeah, 32 years of age. She has come to the hospital. The complaint is tummy pain. Talk to her, assess and manage. Yeah. So the thing is, how can I help you? I have got tummy pain for the last 2-3 hours. Pain last 2-3 hours. What I'm gonna do? I'm gonna do my Socrates. I'm gonna do my Socrates. So 2-3 hours. So is there anything makes it worse? Anything makes it better? Is it throughout for the last 2-3 hours? Is it comes and goes? Did you try anything? If it is helping you or not? Ask all those questions and all. That's really, really important, right? When you ask other things and all, this patient will give you a history that I had C-section 2 days ago. This patient had 2 days ago the cesarean section. And may I know? I think that's a strong question. So anything else? Yes. And 2 days ago, and this patient tells you that my labor was prolonged for 30 hours. Even this information sometimes is given, maybe given to you in the question itself, that patient had cesarean section. That was 2 days ago. The labor, why it was done? Because labor was prolonged, and that was like for around 30 hours. So what happened is when the labor was prolonged, so we may have to do the examination again and again and again, isn't it? So the chances of infection, the chances of endometritis is gonna increase, is gonna be quite high. And that's what has happened here as well. So we have got pain. What we did Socrates. We understood maybe from the question, or the patient will give you the information that I had this cesarean section, and the labor was prolonged. That is the main thing. I was having bleeding from vagina, which is common, but how much was the bleeding and all? So you can ask. Any vaginal discharge now if patient is having, an UTI question, any burning sensation while passing urine, and all if patient has got or not. So these are the things which are very important. Also check out what patient is already taking, right? That's really important as well, because we have to do the pain management. Uh, Guys, main thing, tummy pain, you have to look for few things. Number one, I want you to look for urine. Number two, I want you to look for bowel. Number three, I want to look for infection. And number four, I want you to look for any internal bleeding. Another thing that I definitely want you to look for is the breastfeeding part. You have to be very careful, because what is the presenting complaint? Pain. So I have to do some pain management as well. What I'm giving, what I'm missing, I have to be very careful, because there are certain medications, if given, can lead to neonatal respiratory depression as well. So I have to be very careful on that. So how I'm going to do it? First, pain, I'll do full Socrates. I got to know that patient had cesarean section, the labor was prolonged. Okay. Then ask about the urine, if the patient is able to pass urine properly or not, if there is any burning sensation or not. I'll ask the patient if she is able to pass wind, if she is able to pass feces or not, right? Infection, I'll ask if the patient has got any fever or not. Yeah. Or else, what else I can do for fever, for infection, I'll be able to check the vitals of my patient as well in the later part. For internal bleeding, what I can check for, how can I check for? I think examination will be helpful. Moreover, if the patient has got internal bleeding, the vitals are not going to be okay. So I'll be checking the vitals in the later part of the station. So that's what I have to do. So I'll do the vital general physical examination and examine your tummy, and we'll be doing some blood test, urine test, and maybe we can take pelvic swabs as well. That's what we do. So here what happened is prolonged labor. Prolonged labor. There we have to do the examination again and again. It can give rise to infection of the lining of the womb, known as endometritis. The chances are like around 25% if it is prolonged labor and we did the delivery with cesarean section. So its chances like 1/4 of your patients, they might develop this infection. Okay. So what you have told me and everything, we got to know that we understood that you may have a condition called endometritis, which is infection of your womb lining. It's common after cesarean section, especially if the labor was prolonged. So we may consider doing your urine culture and pelvic ultrasound as well. So we can do some further investigations as well. Now, what is the treatment? The main guidelines, RCOG and the NICE-CKS guidelines, what they say, if the patient is not feeling well, usually the combination, you admit the patient and the combination of clindamycin with gentamicin, that's given. Clinda and gentamicin. They say patient is feeling okay, then we may be able to go for oral antibiotics as well. But mostly we try to go with the combination of Clinda and gentamicin. Again, in the exam, if you are not able to remember the name of the antibiotics, that's absolutely okay. There's nothing much to worry about it. What we know is we have to give antibiotics to this patient. So maybe what we can do, admit the patient, Clinda and Genta, IV fluids, make sure patient is not dehydrated and all. Monitoring of the vitals, that's really important. And hospital stay until symptom improves. Switch to oral antibiotics once the patient is stable. And the antibiotics we are giving, obviously, it should be fine. Your patient definitely can continue the breastfeeding. Risk of complications if untreated. So we have to treat it, otherwise patient can end up having lots of complications. One is infertility as well. And give the warning signs, because what is happening here, patient is having pain, they might have nausea, vomiting. So tell the patient, if you feel good, any drowsy and all, let us know. That is the main thing, right? Now the question comes for the pain. A patient is having pain, and in this country, we have to be very careful, and we have to make sure patient is not in pain. That is the main thing. Patient should not be in pain. So what I can do for that? And the patient is doing the breastfeeding as well, and taking only paracetamol. So when we ask the patient is taking only paracetamol. So what our pain ladder says, first thing is paracetamol plus minus adjuvants. Yeah. And second is usually weak opioids, adjuvants. Yeah. And if I go with number three, we go with strong opioids, paracetamol, and adjuvants. That is the main thing, right? And the guideline says paracetamol is one of the best medication. If you want to achieve best analgesia, you have to give paracetamol as well. Even if you're giving morphine, but if you want to achieve the best analgesia, you have to give it with paracetamol. That's what it is. So if in the history, if you see, this patient is saying, I am trying taking this paracetamol, but it's not helping me. So, and this patient is doing the breastfeeding as well. So now what I am supposed to give it to my patient? I'm here in this line. So patient is in pain. So first you can check how many paracetamol this patient is taking, right? If patient is saying I'm just taking once in a day, then obviously it's not enough. So what you will do, you will tell the patient to take it more frequently, isn't it? Maybe 4 times a day you can easily take it, right? And if patient is in the hospital, obviously I can give IV paracetamol as well if there is any problem with the oral intake, right? If not, then I can add ibuprofen, or I can go with weak opioids as well. Now remember one thing, guys, weak opioids, I mean cocodamol. Weak opioid is cocodamol, which is codeine, isn't it? That's what I mean. Now remember one thing, if a patient is doing breastfeeding after delivery, codeine is contraindicated. So cocodamol is contraindicated. But instead of codeine, what you can give dihydrocodeine. Codeine is contraindicated because codeine has got the maximum chances of neonatal respiratory depression. But can I give dihydrocodeine? That is fine. Obviously, I'll say I'll keep an eye on the vitals as well, and I'll inform my senior as well. You can mention those safety netting parts, but dihydrocodeine is absolutely fine. So we give a combination which is paracetamol plus dihydrocodeine, and the combination is known as codidramol. This is okay. So we can give this one, but codamol is contraindicated. Remember, if the patient is doing breastfeeding, see all the opioids, they're going to increase the chances of neonatal respiratory depression. Say it is codeine, dihydrocodeine, morphine, everything. But the guidelines says, the new guidelines, even if you're giving morphine, it's okay. Even if you're giving dihydrocodeine, it's okay. Codeine is not okay because codeine has got the maximum chances of neonatal respiratory depression. So we can go with this codidramol. That's okay. Cocodamol is contraindicated. So this scenario, you have to do the pain management as well. And this scenario, you have to manage this infection as well. So it's a very complicated scenario. I won't say it's easy scenario. It's a kind of a complicated scenario. So you have got pain as well, and you've got infection as well, right? So, and please, whenever after cesarean, after delivery, you are looking for pain infection, don't miss out these 3, 4 things: urine, they're able to pass or not. Because if they're not able to pass urine properly, UTI, that could be a reason of tummy pain. Bowel, because they're not able to pass wind in obstruction, they're not able to pass feces, that could be a reason of pain as well. Infection is the reason, internal bleeding could be the reason, and ask if he or she's doing the breastfeeding or not. These 5 things are very, very important, written in the NICE CKS guidelines. Do not miss these 5 points, right? And the management is obviously giving antibiotics, doing pelvic ultrasound, taking urine culture as well, fluids, and all those things. All these medication are safe for my baby? Yes, yes, yes. Right? So that's what we have got in infection endometritis. All right. Okay, so we'll go with this quick scenario, mesothelioma. You're a fighter in medicine. Patient is 60, came for the chest X-ray report, and X-ray shows bilateral pleural thickening. Talk to him, assess, and discuss this report. Bilateral pleural thickening, not a good sign. It's a sign of mesothelioma. Patient might be working in asbestos industry, and it might be a case of lung cancer. All right, so what you need to do is, I'm here for my X-ray report. Okay, and then what I'll do, okay, I've got your Excel report with me, and before I explain it to you, I would like to ask you some question. I want to do a quick assessment of you. I just want to know why you had this X-ray. The patient had a fall a few days back, and my doctor had requested for it. How this fall happened and all, you can ask a bit of things. So it is kind of an accidental finding according to this question, right? But then when we know bilateral pleural thickening, so we know the reason is cancer. It can be in some infection as well, like tuberculosis and all. So what you need to do, now you start asking question. You ask question, any other problem? Any cough, any shortness of breath, any loss of weight, any appetite loss, any palpitation, heart racing, you feel tired or malaise these days, any fever, flu-like symptom, any night sweating if you have got, any lumps and bumps, any part of the body, right? Any problem with the swelling. So all those questions that you ask in normal cancer question or infection, you will ask here as well. All right. And then a quick past personal social history. Make sure you are not missing smoking. You are not missing occupation. And you are not missing family. Right? And would like to do your chest examination, some investigation, routine blood, and sputum test as well. Okay, and then you explain it to the patient, do a very good eyes, and after that you will explain there is a possibility of cancer as well, right? I discussed it already, I discussed it yesterday, I mean, we discussed it previously as well, so I don't want to go into detailing. So as patient has and the medicine, so fine, what we're going to do, we're going to admit this patient. If the patient is in the respiratory department, we're going to admit this patient, we're going to carry out further investigations as well. All right, because the X-ray shows that there is some thickening in the lining of your lungs. It could be, because of many reasons. One of the reasons could be infection as well. But when I asked you the question, you didn't have any sign of infection, but it could be something serious as well. Serious could be, it could be lung cancer as well, right? So that's what we need to do. So if you're in the GP, 2 weeks referral, but if it is a specialist, you'll admit the patient and you will investigate the patient, right? And mesothelioma is not very easy to treat. It's gonna be tricky, and it depends on the treatment. Depends on many things. Treatment depends on if it is cancer or not, first of all, and where exactly the cancer is, what's the size of it, if it is in one place, if it has spread or not. So you have to see a lot of things, right? And the treatment is not only me who's going to decide, it's going to be decided by the MDT, multidisciplinary team. So the radiologist, chemotherapist, surgeon, occupational therapist, nurses, GPs, everybody's going to sit together and then decide on that, right? So same thing, I'm not going to go in detailing of it, but yes, bilateral pleural thickening, mesothelioma, asbestos, TB, just keep these things in your mind. All right. Okay, the next one. All right, let's have a discussion on Down syndrome. Yeah, FY2 and surgery. Patient is 46, Lizzie. She's got some concern. Talk to her, address her concern, and manage. So as we discussed, like now, most of the questions are coming like this only. Like the person has got some concern, go and talk to her, right? So how can I help? I want to know whether I'm at risk of getting a child with the Down syndrome. That's her question, straightforward. So what happened is now you started having a bit of chat, right? Again, don't conclude. I've seen a lot of candidates. I know I'm worried about getting a child with Down syndrome. Then we straight away like, yes, there are chances. I'll go and do some investigation for you. I'll do some screening test. Don't do these things straight away. Take a bit of history. Okay. So you're worried about uh, Down syndrome, that your child might have Down syndrome. So can you tell me a bit more about it? What's happening? The thing is, doctor, I am 46 years of age, and I heard that I'm at risk. I'm at risk. Okay, so are you pregnant? Yes, yes. I got to know yesterday that I'm pregnant. I got to know recently, just yesterday, that I'm pregnant. Is it your first pregnancy? Not really. I've got two kids. How are your kids? How they were born, normal, or any problem with them? Are they everything okay with them? Yeah. So yes, it's my third. I've got two children. One is 16, one is 15, and children are healthy. Okay. So you're worried about Downs. How much you know about this condition, Down syndrome? How much do you know? The thing is, I don't know much. What I know is somebody who is pregnant in this age, like 46. I am at I'm 46, so the chances of Down syndrome is high. How do you got to know? Because my friend has a Down syndrome child, and she was pregnant when she was 45. So what my understanding is that if you are I mean, your age is increasing, the chances of getting a child with Down syndrome is gonna be high. Okay, you're absolutely right. The thing is, we have got some tests, but those tests are not very much confirmatory as well. Yeah. As she's pregnant, what you need to do is you need to go with quick past personal social history as well for the pregnancy. Okay, I'm gonna manage this question, but I just want to know if is everything all right with you? Any tummy pain, any nausea, vomiting, any breast tenderness? Any headache, for example. So just quick questionnaire you can do. Any past medical history this patient has got, right? A quick checkup of pregnancy you can do. Any headache, any eye problem, no, any nausea, vomiting, any breast tenderness, any bleeding from vagina, any tummy pain. Ask a couple of questions for her pregnancy as well. Okay. And obviously, then what else you need to ask is you need to ask if there is a family history of Down syndrome or any other kid at home. That's really important as well. All right. And then the lifestyle history also you can take. See, then you will start doing some counseling about Down syndrome. So Down syndrome is caused by an extra copy of chromosomal 21. So we know it's a 21, it's a trisomy of 21st one. Yeah, chromosome 21, trisomy. So when you have an extra copy of chromosome 21, which affects the development. But remember, see, every child is unique, and with support, people with Down syndrome can lead fulfilling lives as well, right? So that's something that you can mention. Now, what is the main thing now you have to do is you have to explain that we have got screening tests as well. So we have got the screening test, we have got the combined test. So you can explain that these combined tests we can do at the age of pregnancy 11 to 14 weeks. I can't do anything now as you got to know pregnancy, as you got to know about pregnancy yesterday only. So there is nothing that I can do now, but the screening test, that is a combined test that can be done between age 11 and 14 of pregnancy. What we do combined, we do blood test and we do ultrasound. Okay, so in terms of blood test, which blood test we do? We do PAPA, that is pregnancy associated plasma protein A. So pregnancy uh, associated plasma protein A, and second is beta HCG. These two tests they do, blood test, and we do ultrasound scan as well to find out this knuckle translucency. When you're pregnant, usually the first ultrasound is done during this age only. It's at the age 11, 12, 13 weeks of pregnancy only. And they do the blood test for screening of Down syndrome as well. Another thing I see, whenever somebody is worried or if they're not worried as well, this Down syndrome screening is not done for everyone. is not done for everyone. Usually, the doctors, or I would say the midwife, they ask the patient if you want to go ahead with this test or not. The reason why this reason, you might be thinking, why somebody will say no to this test. Yes, because there are some religious, cultural beliefs that might actually influence their decision for screening as well. Some of the religion, they're like, no matter what kind of child I'm going to have, I'm not going to abort it, no matter what. So there's no point of doing the screening and all. So that's why. So that's what I'm trying to say is this Down syndrome screening, which is offered between week 11 to 14 weeks of pregnancy, where we do the blood test and ultrasound. We offer it. Ultrasound is done, but you will see some religious people, they don't even go for ultrasound scan as well, right? But ultrasound routinely it's done at 11, 12 weeks as well. But this blood test, as I said, it is optional. It is optional. If you want to go for it, yes, they will offer it to you. You have to give consent for it. And many a times you will see the females, they don't give consent as well. Because what happens is, if the risk is high, I mean, the blood test when you do is not going to tell you that your child is having Down syndrome. No, it will tell you your child is having low risk or very high risk of getting Down syndrome. Even if you are okay, they will say your child has got a risk of having Down. Your child is at risk of having Down syndrome, maybe 1 in 200,000. That's a very low risk. If it is a bit higher risk, they might say it is 1 in 300, 500. So it's not going to tell you straight away that your child is going to have Down syndrome, but it's going to give you a risk. Is it low risk or very high risk? So usually you have to have consent, and many times you'll see the parents, the females, they don't give consent for it as well. Okay. So this test is not mandatory, it's kind of optional. Yeah. If the risk is high, it doesn't mean you'll definitely have a child of Down syndrome. And if the risk is very low, it doesn't mean you cannot have a child of Down syndrome. So it's a bit tricky. But the thing is, if you have got high chances of having a kid with Down syndrome, we do some further diagnostic tests as well. What are these tests? Number one is the chronic villus sampling, and we also do amniocentesis as well. Only if we found the risk of having a Down syndrome child is high. So these diagnostic tests gives a clear picture, but they come with a small risk of miscarriages as well. It's completely normal to feel worried about the results. These tests can risk, and they cannot guarantee if your baby will have Down syndrome. Even if the results show higher risk, it doesn't mean your baby will have it. And if the results show a low risk, that's still a very chance it could happen, right? Whatever the results, we will be here to guide you and support you. We'll help you to understand your options and be with you at every step, no matter what the outcome is. Your care will stay the same throughout your pregnancy. Right? So that's a bit of counseling you can do. What we do, the screening tests are done at the age of 11 to 14, combined test, that's a blood test for Papa A and beta HCG and an ultrasound scan. That's what is done, right? And if the risk is found higher, then we go for CVS and amniocentesis as well. Okay. Now, we have got this quadruple test as well. That's done between 14 to 20 weeks, where quadruple test, meaning you do four hormones you check. AFP, HCG, estriol, and inhibin A. The thing is, we usually don't do it. It's done in second trimester, but we don't do it. Usually we go for combined test, which is much better actually. However, what happened is maybe the parents, the mother, she didn't give you the consent to do the combined test for Papa A or beta HCG in this 11 to 14 weeks. You didn't do it. But now they're like, no, I want to have some test for Down syndrome. So now the time has passed, 14 weeks has already been done. So you may not be able to do Papa A or beta HCG. In that case, only you do quadruple test. So routinely it's not offered. It's not offered. What we offer is that is the combined test. We don't offer quadruple test. However, because of any reason, because we didn't get the consent from the parents or whatsoever, we didn't do it. And now later on, after 14 weeks, they're like, no, I want to have another test. Then we may be able to do quadruple test. Otherwise, not routinely done. Right? So when we get the risk is high, in these tests, the ultrasound and the blood test, the risk is high, then only we can go for CVS or amino tests, right? So that's what we have to do. So in terms of history, what are the questions that you are asking? The question that you're asking is about her pregnancy, or everything like any headache, any eye problem, nausea, vomiting, breast tenderness, bleeding, swelling in the legs and all. Is it your first pregnancy? How are your previous kids? If they're okay, they're healthy, there's a family history of Down syndrome or not in your family, So these are the questions that you need to ask. And then you do a counseling that yes, you're right. As the age increases, the chances of having a child with Downs is high. And what is down is it's extracorporeal chromosomal 21, which affects the development. But remember, every child is unique, and with support, people with Down syndrome can lead fulfilled life. So you are looking for this. We have got some screening tests. But screening is for screening purpose. It's not going to confirm that your child will or will not have Down syndrome. It can tell you if the child is at a high risk or low risk, right? So the test is done at 11, 14 weeks, but it's optional test. If you give consent, we can go for it, right? Because of some personal beliefs and all, a lot of people, they may not be going ahead with that. All right, so that's what you have got for Down syndrome counseling. All right. Okay. The next is tremors, essential tremors. You're halfway to in surgery, GP surgery. You've got a young patient and complains of tremors in his hands. Right. Again, tremors, there can be lots of reason behind it. Or sometime when we say essential tremors, which means there is no reason behind it. It just happened. Why? Because of stress, maybe. So there's no reason behind it. Easy stations to manage, but we definitely want to see if you are ruling out some secondary causes or not. And that's really important. Yeah. How can I help you? Uh, I have tremors, my hands are sick, shaking. Then what I'm gonna do? I'm gonna do my elaboration. I'm gonna do my OD para, right? I'm gonna elaborate it. So tell me more about this shaking. For how long you've been having it? Is it all the time? If it comes and goes, is it like at rest? Is it like when you do some work? Is it only then? Are you able to do your daily routine things properly or not? Anything makes it worse? Anything makes it better? And yeah, all those questions, I mean, you can ask. Yeah. Fine. Now, what else you can do is you can try ruling out some differentials as well. You can try ruling out some differentials as well. For example, the tremors, you will see it's there if you have got thyroid. It's there if you are having any drugs. If you're taking any drugs, it can be there as well. Parkinson as well, but I would say less likely. My patient is quite young, isn't it? My patient is 27. So that's a tricky part here. But yeah, okay. So I'll do Odipara when it gets worse, when it is getting better, right? It's happening for a while now, but it seems to get worse at times. Okay. And then what I'm going to do, I will try ruling out some differentials as well. If the patient is a diagnosed case of anything like any diabetes, any thyroid problem mainly, right? And why I'm asking about this weakness, unsteadiness, dizziness because of some secondary problem, right? So maybe MS and all, multiple sclerosis and all, fall and all, you can ask those things as well. Trouble in walking, eye problem, you can ask as well because of thyroid, because of MS as well. Okay. How's your mood? You're leaving, stressful, quick, past personal history as well. I would like to do general physical vitals and neurological examination, blood test, UNE, liver kidney function test as well. When you're doing the lifestyle history, do not miss this smoking, alcohol, caffeine, all those things. That is really, really important because caffeine is the reason maybe that's making it worse, right? From our assessment, we suspect you have got essential tremor, which is a condition that causes a shaking in the hands and sometimes the other parts of the body. It's fairly common condition that runs in the family. And I understand you mentioned no one in your family has had it before. This type of tremor is not caused by any other illness and often improves with medication. That's the main thing, right? So, essential tremors, nothing to worry, but what you need to do, you need to make sure you rule out the secondary causes if there are any reason behind it. That's the main thing. Treatment is lifestyle only, so just need to work on the trigger factors. So mainly the patient will tell you the trigger factor is mainly the stress. So stress management, yoga, meditation, there's caffeine sometime, or sometimes the patient might take, I'm taking certain medications. That could be the reason as well. Okay. Then medications can be given as well. Usually the beta blocker, propranolol, that can be given as well, right? I mean, I think you must have seen, for example, when you are stressed and you're doing the mannequin, you're doing blood sampling, you're doing a cannulation. So what happened is we started having the tremors while doing it, right? So do you have any secondary causes? Not really, but it happens. Why? Because of stress. So that is what we call as essential tremors. So the simply thing, the tremor that we can get it while doing a cannulation or blood sampling in a mannequin, for example, that is your essential tremor. There's no reason behind it, but why it is there? Because of stress, right? But some people you'll see it can get worse with the tea, coffee as well, or maybe they're under, they're taking certain medications as well. That's why a lot of people ask me, can I take beta blocker? Can I take propranolol when I'm going to go for my exam? My answer would be don't try anything which you have not tried before. Don't try anything just before the exam because it can make you slow as well. So be careful about these things, right? Physical therapies, like some patients find that physical therapy can help to control these things. Surgical options, but that's rare. You don't need to go into that much. Patient might ask, is it Parkinson's? You know the answer, it's not. And we don't expect a patient to have Parkinson's at this young age as well, 27, isn't it? And if you are thinking about Parkinson's, just make sure you rule out, you can ask questions for Parkinson as well. So in Parkinson, three things that you need to know is they have resting tremors, pin rolling. That's one. Number two is that they have got muscle rigidity. And third thing they'll have is bradykinesia. Right? So you can ask these questions in the history, but less likely it is Parkinson's. Why patient is 27? All right, so that's what you have got in essential tremors. Essential tremors, there is no reason behind it. You just get some tremors while doing something. It's because of mainly stress or maybe alcohol, maybe tea, coffee. But yeah, we need to try making sure that we are finding it out if there are any secondary causes like thyroid, diabetes, or Parkinson, or MS, or any drug if patient is taking. So just try finding these things out. All right, so that's what we have got in essential tremors. All right, so the next one we have is metformin-associated lactic acidosis. In short, you can say MALA. Right, it's a rare situation. It's a rare condition. You don't see it quite often happening with the patient, but if the patient is on metformin, yeah, it can happen. You have to think about this as well. Your FY2 in GP surgery, it might be GP setting or it might be A&E setting as well. The reason is, see, if this is tired, but this patient can have other symptoms like a small breathing as well. If that's the case, patient might not be coming to the GP surgery because for GP surgery, you have to book an appointment. In A&E, I can go walk in. I cannot go walk into the GP surgery. So these cases mostly you will see in A&E. Patient is Mr. James, 45 years, has called in with the complaint of tiredness. Okay, so this can come as a teleconsultation as well, can come as in-person consultation as well, right? So maybe patient has booked an appointment in the GP or patient is calling A&E straight away as well. In teleconsultation, what happens is the question comes is who is calling? Is it the patient calling the doctor or doctor is calling the patient? Mainly what happen is it is the doctor who calls the patient because when patient has a problem, they call the surgery and book the appointment. And at the proper time, whenever the time is, then doctor make the call to the patient. That's what happens routinely, right? But if it is an emergency case, it might be a patient calling A&E straight away as well. Okay, so the scenario might be in the A&E, might be in the GP as well, right? So the last time, couple of time when this station came, it came as a teleconsultation. Can come as in-person consultation as well. Doesn't make any difference at all. Okay, sometime maybe what might have happened, I'm just telling you different ways the station might come. Maybe this patient has made a call not to the 999, maybe made a call to 111. What is 111 number for? 111 is for non-emergency cases. Emergency is 999. But if you have a problem, it's not an emergency, you might be calling 111 as well. So somebody's going to listen to you and then they'll put you in contact with the relevant people and then the specialist is going to call you in some time. And then they will be going with a bit more detailed history. Okay. Okay, so has called you with the complaint of tiredness and is a diagnosed case of type 2 DM and is on metformin. Talk to him and manage. How can I help? So make sure if it is teleconsultation, you are just doing all the things needed for teleconsultations properly, meaning you have to confirm number one, you have to confirm three identities. That's going to be the name, age or date of birth. And the third thing is the address of the patient, right? So the address and all these things will be given to you in the cubicle. So do not miss these points. So confirm three ID proofs. And then obviously ask if it is a good time to talk. Yeah. And the third thing would be, are you able to hear me clearly? That is the main thing, right? So these are the things that you can do. Okay, so any teleconsultation, you are supposed to do these things, and the address and all this extra information will be given to you in the cubicle as well. And when you go in, you may not have the examiner in the cubicle as well. So that's fine. You can just move on. Yeah. How can I help you? I'm feeling tired since I woke up this morning. Okay, tell me more. Tell me more. The thing is, since I woke up, I'm having problems. So this is something very concerning, right? So symptoms started just this morning. Is it getting worse since the morning? That is something that you can ask, right? Anything else? This patient is saying, I'm breathing faster than usual. You know, the lactic acidosis, this MALA, metformin associated lactic acidosis, the patient can have cosmol breathing as well, which is faster breathing. When you have got these two things in the history, that patient is feeling tired since morning and the patient is having this faster breathing as well. So you have to be very careful now. So we can ask some other questions associated with the MALA, lactic acidosis. For example, if the patient is feeling dizzy, any confusion, any nausea, vomiting, any tummy pain, any muscle cramp, any chest pain, any palpitation. Patient is diagnosed case of diabetes. I'll ask about diabetes as well. So you're taking this metformin. Are you taking it regularly? Are you taking it as prescribed? By any chance, any missed dose? If your diabetes is well controlled, and are you taking the medication? I mean, are you checking your blood sugar regularly? When was the last time you checked? If you have got symptoms of diabetes, if you have got any complication of diabetes, if you have got any episodes of low blood sugar, ask all those questions. I think you'll have enough questions to ask in the history. So elaborate your tiredness, elaborate your breathing faster than usual, and then ask some more questions about MALA, ask some question about diabetes as well. That's the main thing, right? And I'm going to do general physical vitals and neurological examination, blood test, ABG, UNE, LFT, KFT, these things that we can do. Right. Now, if the patient is calling you, can you do these blood tests over the phone? Not possible. And we understand if it is lactic acidosis, metformin associated, it is an emergency as well. Otherwise, it can be life-threatening as well. So what you need to do, you are over the phone. So are you going to tell the patient to call the ambulance? Are you going to tell the patient to come to the emergency? Not really. What I would say, I am going to call them. That is something that you need to do. You have to be very careful. See, this patient might collapse the next second. So if you tell the patient you just cut the call and call the ambulance, he might not be in a situation to do that, right? So it's you who's going to call the ambulance, right? Second thing, if you see, I've taken the address of the patient already because why address is so important. So I think you'll be able to relate things here. Why address is important. So I'm talking to this patient and all of a sudden this patient can't communicate with me. So what I need in that case, I need to have the address. I already have the address, or at least I can send the ambulance to that address. That is the main reason. Okay. So you can explain that lactic acidosis is a rare condition, but it is a serious condition that happens when too much of lactic acid builds up in your body. It's a natural substance produced by the muscles and the RBC, but your liver and kidneys usually help to remove it. Metformin is a medication that we give for diabetes. In rare cases, it can lead to a condition called MALA. This happens when the body cannot clear lactic acid properly, and it can be dangerous as well. All right, so I'm going to call the ambulance. The treatment is uh, in the hospital. What we're going to do, we're going to admit you in the hospital. Number one is we'll be giving IV fluids. The main treatment is IV fluids, IV fluids, IV fluids. Yeah. Second is obviously you're gonna stop metformin. You're gonna stop metformin. Now a question comes. A lot of candidates ask me: are we gonna give activated charcoal or not? See, activated charcoal can be given in any scenario when they have taken the drugs just now. But they say the metformin absorption is actually very fast if they've taken, right? So activated charcoal has got very little or no role to play in the management of mala. So I would not recommend you to mention it. So mainly what you need to mention is IV fluids, stop your metformin, right? And definitely we'll be keeping an eye on your liver kidney function test as well. That's the main thing. And the main treatment that you might be doing is giving sodium bicarbonate in extreme cases. Obviously, I'm going to do ABG, and that will give me a bit better idea as well. And in severe cases, we might be going for dialysis as well. Make sure your patient is not dehydrated. That's the main thing. Yeah. So that's really important here. Right, so your differentials will be like if the patient is having DKA, for example. So DKA will have other symptoms as well. And obviously, here I will be able to do the urine test as well to have some ketones. So that is the main thing. And DKA you usually you'll see when patient is starving, not eating something. So then there are chances that might go into DKA. But this patient is eating as well, right? And do ABG, do urine test. And I think that's how we can conclude if the patient has got lactic acidosis. Treatment is admitting the patient. That's the main thing. And IV fluids, stopping morphine, this metformin and sodium bicarbonate, depending on obviously the blood levels you need to check here, and accordingly we'll see. And we might be going for dialysis as well. So that is the main thing that you need to do, right? Monitor for any new symptoms and let the family member know so they can help you, support you, and follow up with the GP or diabetes for your further assessments as well, right? Take precautions in the future by staying hydrated, avoiding excess alcohol, and informing your doctors if you become unwell. All those things that we can mention, right? So that's what you have to do in this scenario if you get a scenario on lactic acidosis. All right. All right. Have a look at this one. You're FY2 in GP. Female, Daisy. She's 40. She's come to you with some concern. She has a daughter. She has a child, 2 months old. The child has got a yellow color rash on the head. Talk to her and address her concern. So it's a pediatric case or a dermatological case, actually. Skin dermatology, mostly you'll be able to make the diagnosis when you have a picture. Right, so picture, it depends. I mean, can I see the picture in the beginning? Yes, but I would recommend see it in the later part of the station. But mostly dermatological scenario, they're also coming as teleconsultation. And the task will say that the mother has booked the appointment for her 2 months old kid because she has noticed some rash in his head. She has already emailed the picture of the rash. You can find the picture in the cubicle. So in this case, actually, the life becomes easy. When you go in the cubicle, you will be having the rash picture on the table, which makes your life easy, right? So if it is a teleconsultation, you're going to confirm the name, age, address. Are you able to hear me clearly? Is it a good time to talk? All those things you will do, and then you'll start the consultation. All right. So I'll show you the picture, but let's do it without picture first. Let's see how we can make the diagnosis. How can I help you? My baby has developed a yellow rash on his head and I'm worried. Yeah, rash. Okay. Tell me a bit more about it. I just noticed like a week ago or 2 weeks ago, do a bit of Odipara here. And you know how to do the history for any rash, right? So if there is any redness, any ulceration, if there's any bleeding coming out, if it is increasing in size or not, and if it has changed in his size, shape, color, all those questions that you can ask. All right. So elaborate it properly. Anything makes it worse, anything makes it better. Have you tried anything? Yes, I've been washing his hair with baby shampoo, but it is not working. Okay, you can ask if there's any itching, any pain, all those things that you can ask, any redness, any swelling, all those questions. Now, whenever it comes to a child case, what you need to do, you need to make sure you're doing a quick screening if the child is healthy or not. Right? Rash is there, so I have to look for meningitis, fever, all those questions. So quickly cover those things as well. That's really, really important, right? So ask for any fever, any chills, change in the behavior. If the child is playful, child is taking the meal, eating, drinking well or not, all those questions you need to ask. Then you can quickly do birth history as well. How was the birth of the child? If you're happy with the immunization, if you're happy with the developmental milestone, any recent jab, and if he's formula fed or bottle fed, any recent changes in the diet plan, how is urine and stool, all those questions you can ask. Right? Also, the patient has got the rash. Is it only on the head or is it on the face as well? Is it also on the chest as well? Is it also on the nappy areas as well or not? Ask those questions as well. All right, and do the red flags, any fever, any meningitis, any like urine problem, tummy problem, crying excessively, not drinking meal, and is very cranky or not. Ask all those things, right? Then what happened is when you say, I would like to examine, this is what they give it to us. What comes in your mind if you see this head? So this is cradle cap, right? This is cradle cap, which is common and harmless skin condition. In infants, it appears a yellow, greasy, scaly patches, and sometimes on the face as well, and also sometimes on the nappy areas as well. Okay, so what's the management? It's caused by the overproduction of natural oil on the baby's skin. It's not because of poor hygiene. It's not because of poor hygiene. All right. All right. And so the treatment is continue washing your baby's scalp with mild baby shampoo. Sometimes what happens is the parents, they might be going for very, what do you say? Adult shampoo, which is very harsh. Don't do that, right? So just continue washing your baby's head. You can gently loosen your scales using a soft baby brush or maybe with your finger as well. If it is happening, if it's not happening, just don't worry about it, right? If it is persistent, you can try something else as well. You can apply a small amount of baby oil or maybe petroleum jelly before washing can help to loosen the scale. Some people, they say coconut oil, that is also helpful. And a lot of people they use it, but we couldn't find it on the NHS. NHS website is not mentioning it actually. Just be very careful. Don't go with olive oil. That is not given. Even make sure you avoid peanut oil as well. See, in the Western countries, mostly what happens is there are lots of allergies, mainly say, for example, from peanuts and all. So if you go for peanut oil, may not be a good idea, right? So I would say go with what is written in the NHS guidelines. So I will go with a small amount of baby oil or petroleum jelly so that it can loosen the scales. As I said, parents, they use coconut oil as well, which is okay, but olive oil and peanut oil is a big no. Yeah. Medicated shampoo, ketoconazole, that can be used as well after you get advice from the GP, from the doctors. I mean, you don't need to really do it. I mean, try these for persistent cases first. Yeah. Most of the cases for pediatrics that we have got, they are actually reassurance scenarios. Even cradle cap, this is also a reassurance scenario, but you need to be very careful. You have to mention when we have to be alarmed. That is the main thing. So, what is the reason of worry? So, do not pick at these scales as it may lead to irritation or infection. Avoid harsh shampoo and excessive washing as it can make the skin drier and can make the things worse. When to seek medical help? What is the red flag sign? If the rash spreads extensively, become red, swollen, or start oozing out, that is a sign of infection. Make sure you go to the hospital. Another is if baby seems unwell, having fever, not eating, drinking, excessive crying, go for it. Yeah. Cradle cap, it takes time. It takes a couple of months. It can take like a few months before it get cleared up completely. Harmless and should clear up over time. Most cases on 6 to 12 months of age. If it doesn't improve or worsens despite the treatment, you definitely can go to the clinic for the follow-up. Right? So that's what you have to do. So mostly the pediatric cases are actually reassurance scenario, but you need to ask the red flag questions. You need to give reassurance properly, and then you need to give proper warning signs as well. All right. So that's what we have got in cradle cap. OCD, obsessive compulsive disorder. Yeah, FY2 in GP surgery. 24 years, final medical student, maybe age is 20. He's struggling to complete his walk. Talk to him, assess him, and manage. Right. So, how can I help? I can't seem to do my work properly recently. Okay, tell me more. What's been happening? I feel anxious whenever I see patients. What do you mean? I feel that I might catch that infection if I go close to them. And that's why I get anxious and I feel like I must wash my hand immediately multiple times until I feel clean again. So, what is OCD, obsessive compulsive disorder? What happens is you have an obsession. People experience distressing thoughts, actually. That is obsession. And then they feel compelled to do repetitive actions, right? So, this patient is like when I'm going near to the patients, I feel that I might get some infection. So, that is a distressing thought that is coming in his mind. And because of that thought that I might get this infection, this person is compelled to perform a repetitive action, which is cleaning of hands. So you have an obsession, a distressing thought, and because of that thought, you are compelled to do a repetitive action. That is a compulsion. So that's why the name comes obsessive compulsive. So you have an obsession, and because of that, you are doing a compulsive thing, right? So that's the main thing. Yeah. Uh, Another thing is a lot of times you'll see, if you have to take another example for OCD, a lot of people they have even checked their houses that they have uh, put the proper locks in the on the doors and the windows, but still they have a thought obsession that maybe the thieves will come in my house. So they feel compelled to do what? They go and check the locks again and again and again. Another example. So, for example, what can happen is distressing thoughts like, so you are sitting in your room, now you are going out. For going out, you might be just holding the door as well, the knob of the door, and then only you open. So, when you used your hand to open the door, now the distressing thought will come, oh, I touched that knob, I might get some infection. So, what's going to happen? You just go and wash your hand. So that's a repetitive movement, right? So that is what we call as OCD, obsessive compulsive disorder. You have a distressing thought, obsession in your head, and then you compel to do the repetitive action. That's your compulsion. Okay. So this is what this patient is saying. I get anxious when I go close to my patient. I feel like I'm gonna get this infection. So that's what I'm doing. I'm doing this. I'm just washing my hand again and again and again and again. Right. And does this interfere in your daily routine? You can ask for the other things as well. Sometimes the patient says, yes, I keep checking my door locks again and again as well. So that is another sign of OCD. any psychiatric cases you get, what I really want you to do, I really want you to do a quick depression screening as well, right? So, do you feel that these thoughts are excessive? Yes, of course. You can ask about the patient mood. You can ask about the eating appetite. You can ask about the sleeping as well. You can ask about the harming person, like suicide, if you have tried harming yourself or others. So that is going to be very, very, very important here. Okay. Makes sense. Yeah. And now, what is the main reason? So, why this can happen? OCD. There are some risk factors. Risk factor is number one is the family history. Family history is one of the important risk factor. Second risk factor is actually stress. Stress is a very important risk factor, right? Obviously, the person is stressed, a medical student, that can be a reason of stress as well. Sometime what might have had, like a person had a trauma or any life event that can actually trigger OCD, right? So any lifetime event and all that might have happened, any trauma. So that is something can be a risk factor. So what you have to do, you have to try finding the reason. So usually what they do, obviously they're going to give us some reason as well. And you can use those reasons to tell like this could be one of the reason of you having this thing, right? So quick past personal social history as well, because the management is what? Management is going to be the main thing, lifestyle advices as well. So that's why you won't have, you have to take lifestyle history. From what you have told me, it sounds like you have got OCD, obsessive compulsive disorder. It's a condition where people experiencing distressing thoughts, obsession, and feel compelled to perform a repetitive action, compulsion, to ease their anxiety. That is the main thing, right? So in your case, the fear of contamination is leading to excessive hand washing, which is interfering with your daily routine. So that is something you can explain. Management is again, it's a CBT, and management is exposure and response prevention. So what you have to do is you have to expose the patient to this thing. Whatever distressing thoughts that is coming in the patient head, let the patient have those thoughts, but you will not allow the patient to do those repetitive actions. Over time, our brain will learn it, and you will see the anxiety, it's gonna come down. That is the management. So this is the most effective treatment. It helps you gradually face your fears without performing compulsion. So we will put distressing thoughts, but we will not allow you to repeat your actions. So over time, our brain learns it and helps in reducing your anxiety. That's it. So that is the main thing. So CBT is the treatment only, and exposure and response prevention is the treatment. If needed, maybe SSRIs can be given. And I don't want you to say SSRI or the medication in the first attendance to the clinic itself, right? So we try going for non-medical, non-pharmacological treatments only. But if needed, yes, we can go for SSRI as well. But SSRI is also going to be with CBT. It's not like only CBT we are going to, also only SSRI we're going to give, right? Self-help strategies. These are great resources like OCD UK and self-guided CBT programs. Try reducing the number of hand washes gradually. I will like to refer you to the talking therapies for the specialist support, and then we'll do the follow-up after a week or two. That's it, right? So OCD, you're doing something, you have got obsession of something, and that's why you're compelled to do repetitive things. That's your OCD, right? So that's what we have got in OCD as well, obsessive compulsive disorder. All right. Okay, so next one, infective endocarditis. You are FY2 in GP surgery, or they might say in A&E as well. They might say in A&E as well. Yeah. How can I help? 14 has come to you with some concern. Now they have given you something. It says he's on methadone for heroin withdrawal. See, that is the biggest hint that you have got. A person is taking methadone for heroin withdrawal. So we have got the history of drugs, right? Some concern. Now this patient start with hot flushes and fever. So if patient is taking drugs and having fever, we have to think about infective endocarditis, right? So how can I help? I've been having this hot flushes and I've been feeling unwell for the last few days. So what do you do? Tell me more. Tell me more about your feeling unwell or these hot flushes. So this patient is saying, I'm feeling feverish. Have you checked the temperature? Not really. Any chills riders? Yes, sometimes I feel that. Anything else? Like what? So now, as I said, when you have got the drugs, patient is having fever, you have to think about severe infection, which is infective endocarditis. That has to be the first thing that should come in your mind. Okay, so you can ask more questions on infective endocarditis as well. For example, any chest pain, any shortness of breath, any palpitations, any tremors, any sweating, any headache, muscle pain, tiredness, nausea, vomiting. So ask these questions as well. Okay. Patient is taking methadone and patient was taking recreational drugs. So what I want you to do, I want you to do ask more question on the recreational drug, whether the patient was sharing needles or not. That is going to be very, very important thing here. Okay. Does that make sense? So what we got? Patient is feeling unwell and patient was having fever, patient was taking drugs. See, if you see if this information is not given to you in the question, that patient is taking methadone for heroin withdrawal, it is not going to be easy for you to make the diagnosis. I'm not saying I can't make the diagnosis at all, but it is going to be a bit difficult for me. The reason being, patient is having only fever. So what you do, you elaborate on the fever, obviously, right? And try ruling out all the causes of infection. You will do systemic review as well. You will do ICE as well. And if a person is on methadone for heroin withdrawal, they will give you lots of non-verbal cues as well. They'll give you lots of non-verbal cues as well. So if this line is not given to you, don't worry. You'll have lots of non-verbal cues. You'll do systemic review. You will do ICE. You will have your diagnosis. Don't worry. When you have got lots of non-verbal cues, you acknowledge that. You acknowledge that. You will get that history from the patient that I'm taking methadone for my heroin withdrawal. Then the diagnosis is kind of going to be clicking in your head as well. Okay. Right. So what you're going to do, I'm going to do the general physical examination, vitals, and examination of your heart and lungs, and some investigation like routine blood test, and do the urine test as well. All right. And in this, usually what's going to happen, the examiner is going to give you some findings. They usually give us the temperature. The temperature is on the higher side. That's the thing, right? So we can suspect, we can't be sure, but you can suspect that we're suspecting infective endocarditis. It's a serious condition of the heart valves, usually caused by the bacteria entering into the bloodstream. People who have used these drugs, they are at higher risk, and if not treated, this can be life-threatening as well. So what is the treatment? First of all, let's investigate, right? Also, when you do the examination as well, you might get lots of other things like road spots, Janeway lesions and all. That's what we use to make the diagnosis of infective endocarditis. Okay, so now what you have to do here is you have to do the full blood count. Don't miss ESR and CRP. That is the main thing. Blood culture before starting antibiotics, that's really important. And we take the blood from different sites as well. And many times you will see we take 3 blood culture samples from different sites to make sure we are not missing anything, because that is going to be coming in a major criteria for diagnosis of infective endocarditis as well, right? And third thing that you're going to do is the echo. TTE, transesophageal or transthoracic echocardiogram. That's really important to see the infection of the heart valves. So that is really important. Okay, so this is what you have to do. And in the history, you can ask about, when you're asking about heart and lungs as well. So if the patient was operated previously, patient has got prosthetic valve or not, that is really important. In terms of examination, guys, when you're saying examination of the heart, we are actually looking for extra sounds as well, which is murmur. Your patient has got high-grade fever. Your patient is IV drug abuser. And if you got murmur on auscultation, this is nothing other than that. This is nothing but only infective endocarditis. Okay, so that can be your mnemonic. High-grade fever, taking drugs, and if you get a murmur on auscultation, this is infective endocarditis. End of story. All right. So this condition can be life-threatening as well. So what we usually do is we have to go for antibiotics, and we have to go for IV antibiotics, and it's given for a very long time, given for 2, 3, 4, 5, 6 weeks actually. So it depends. We give it for 2 weeks and we'll see the response if the patient is improving or not. If patient is not improving, we'll continue the antibiotics. And sometimes we may have to go for surgical options as well. Surgical option is not like we're gonna go straight away, but if you have got signs like, for example, you have got the valve is very much ruptured, there's a fistulas in the valves and all, or if you see the patient is going into heart failure and all. So sometimes we may have to go for surgical options as well. Maybe valve replacement and all you may have to do as well. And when you feel like there is a fistula, there is too much of problem with the valve, whenever you try to do the surgery, you try to do it as soon as possible. You try not to delay it, because if you delay, the things are going to get worse. And because of it, because of the problem, infective endocarditis, the patient is going to be prone for a lot of other problems as well. So this is something that you need to see as well. This patient is going to be prone for stroke, for TIA, lots of clots, DVT, PE. So you have to be very, very, very careful on that as well, right? So if you feel patient is at higher risk of all those things, you better go with the surgical options as soon as possible, right? So yeah, that's what we have got in infective endocarditis. Yeah, all right. Okay, the next one we have got is a medication overuse headache. Patient is requesting more painkillers. When we take more painkiller, it can give rise to headache. Overuse of medication can lead to headache. So the question is, your FY2 in GP, patient is 38 and presents with the worsening of headache despite taking the painkillers frequently. Take history and the management. So patient is taking the frequently by taking these painkillers, and despite taking the painkillers, patient symptoms are getting worse. So I think the question is telling me the diagnosis. So what brings you today? What brings you in the clinic today? I've been having these headaches for months. What I'm gonna do? I'm gonna do Socrates. Tell me more about it. Yeah. So the patient is going to tell you about it, that it's been a few months I've been taking this medication. It's there in my forehead, behind my everywhere it's there. And then you ask which medication he's been taking. He's taking paracetamol, he's been taking ibuprofen, and taking sumatriptan, taking many, many medications. And is it helping you or not? Yes, it's helping me a bit, but then after some time, the pain starts again. And now I feel it is getting worse. Okay. Headache is there, and I think with the Socrates itself, you will understand that it is because of overuse of this painkiller. Now, what I want you to do is rule out some red flag signs. Rule out some red flags, like for example, any blurring of vision, any loss of vision, SOL, glaucoma, any neurological meningitis. So we know lots of differentials for headache, meningitis, subarachnoid hemorrhage, SOL, glaucoma. Rule out head injury. Ask one question and quickly rule out your red flags, right? Okay, and then quick past personal history as well. A lot of patients, what they do, they have a misconception. They say, if I'm drinking tea and coffee, it makes my headache better. Some patients might say, oh, if I'm taking a glass of wine, it makes my headache better. So lots of misconception I'm saying the patient might have. So yeah, just take quick past personal history as well. I would like to do your general physical examination. Would like to check your vitals and maybe doing a CNS examination as well. The thing is, this headache, you won't get anything in terms of examination or investigation. You have nothing. It is just a clinical diagnosis. It is simply uh, in your history, you will get these things, right? So based on the history assessment, your headache are likely due to the medication overuse headache. It happens when painkillers are taken too frequently. So instead of helping, they start to cause more headaches, and your brain becomes dependent on these medications, and they can have a rebound pain. So that is what you have to explain. Now, what is the management? Management is really interesting. The best way is to stop taking all the painkillers for 4 to 8 weeks. And actually, we want you to stop them all of a sudden. You're taking triptans, you're taking paracetamol, you're taking ibuprofen. You used to stop them at once. So when you stop it, it is gonna make things worse for you. It is gonna make things worse for you. That is the problem. It's gonna make things worse. But the thing is, you encourage the patient for it. Like, yes, it's gonna make things worse, but you can do it. Make sure you're not dehydrated. You do all those like lifestyle things: no smoking, good diet, physical activity. Try to divert yourself in other things. So mention all those things. If we taper it down, would that be better? Or just stopping it all at once is better. So stopping it all at once is much, much better. However, if your patient is taking opioids, if your patient is taking benzodiazepines, then we might be tapering it down and then stopping it. However, if your patient is on paracetamol, ibuprofen, it is better you stop it at once. So initially, headache may get worse before it starts improving because of these withdrawal symptoms. Yeah. So, supportive treatment would be if withdrawal symptoms are severe, a short course of naproxen may help. Again, I don't want you to mention it. The guidelines do mention it, but don't mention it straight away. Let the patient go with this method, like stopping the medication, the painkiller all at once, right? Stay hydrated, reduce your tea, coffee intake, try relaxation techniques, regular exercise, and sleep hygiene. So work on these things. I'm sure it's gonna work. If not, come back to us and we'll see. We might be able to give you some other medications as well. Okay. There are some preventive medications as well if headache persists, and we may consider giving prophylactic medications as well. That's sometimes given like topiramate and amitriptyline as well. Again, I'm not a big fan of these, and I don't want you to mention these things straight away. It is written in the guidelines as I'm writing it here as well, but I wouldn't recommend you to mention these things to the patient. Keeping a headache diary can help identify the triggers as well, right? Tell the patient that the review in 4 weeks, and if the symptoms still persist, we may be able to refer you to the neurology team. And the neurology team, I think they will be the best person to decide to give something for preventive measures or not. So from your side, try not to. So what you're doing, you take history, you do Socrates, rule out the main sinister differentials of headache. All right. And then the treatment is stopping all these medications. That's the main thing. Abruptly need to stop. Encourage the patient. Yes, in the beginning it may get worse, but slowly, in a week, in 2, 3 weeks, you'll start seeing the improvement as well. If you feel it's not improving at all, come back. We'll see what I can do for you. But the best treatment is stop it at once, all of a sudden. However, if patient is telling you I'm taking opioids, then you might considering tapering it down before you stop at once. You can stop, but the withdrawal symptoms can be even more severe. That's why we try not to stop opioids all at once, right? But our patient is taking paracetamol and ibuprofen, so you can stop it. Work more on the lifestyle. Even headache diary to see what are the triggers so we can work on it, and keep yourself hydrated, relaxation, exercises, good diet, and reduce your tea, coffee, and alcohol intake. So that would be the management. So that's what we have got in medication overuse headache. All right. Okay, let's go with the next one. Acne. Acne, it's not like we haven't done previously. We have done it previously as well, but this scenario is a bit interesting. Let's see what I want to add in this. You're after in GP surgery. Your patient is a young male, 28, complaining of acne. Talk to him, assess, and do the management. I've been getting a lot of acne recently, and I want to get rid of it. Okay, fine. So do Odipara a bit more, right? And acne is a kind of rash, isn't it? So you know how to elaborate a rash. So you try doing that. For how long you've been having it? Is it the same? Is it getting worse? What you need to ask is it only on the face or any other part of the body? like on the chest and all, on the neck area, if it is there or not. So that is really, really important. So patient has got acne. You can also ask, what have you tried so far? That's very important as well. Okay. Another thing is a young male. So during the history, when you ask the patient if you're taking any supplements, this and that, this patient will say, I've been taking some bodybuilding supplements as well, and I'm taking a medicine known as D. He won't name it. He's just saying it's D-di. He didn't name it. So what we believe, it was most probably Dynabol. He's taking something, he's going to the gym, he's a bodybuilder, and taking a supplement. I don't know the exact name, but it is something from D. Something starts from D. When I asked, do you have the medication with you? He didn't give the medication to anybody. But most probably what we think it is Dynabol. Now the thing is, when he says that I'm taking these medication, you need to ask, are you taking it as prescribed? Meaning, I want to know if somebody has prescribed this person or not. Is it supervised drug, or is he taking it illegally, illicit drug? Because in the UK, it's not available. Nobody's prescribing it. Nobody's giving it. It's not available in the UK. But yes, a lot of people, they're taking it illegally. Right. So if it is taking as a supervised drug or if it is taking it illegally. So that is very important. And I don't want you to miss that point. Right. So patient has got acne, elaborate the acne a bit more, like for how long you've been having it, anything makes it worse, anything makes it better. Is it only on face or is it anywhere else in the body? And have you done something so far for your acne or not? Right. When you've got acne for a very long time, it actually leads to your low mood and depression as well. So I want you to do quick screening for that as well. Right. And this patient is bodybuilder. So you will ask about if he's taking any supplements. Yes, I'm taking. Is it supervised or if it is illicit drug if he's taking? So that is going to be very, very important. Dynabol, when you take it, it's not supervised, obviously. So one of the side effect is acne. That is the thing we are looking for, right? So what are you going to do? You're going to do some blood test. That is hormonal level you will check. And obviously you will check for the rash as well. They will show you a picture, which is actually a mild acne you have got. Fine. So then you can tell the patient that what we understood is you might be having this steroid-induced acne. Yeah. So it's common people using these steroid like Dynabol. So acne occurs when the hair follicles in your skin becomes blocked with oil and the dead skin cells. Yeah. So that is the main thing. In your case, anabolic steroid can increase oil production, leading to clogged spores, causing thickening of the skin, trapping bacteria inside, promoting inflammation, leading to the acne. That's what you can say. Now, what you need to do, you need to do some blood test as well. Blood tests are very important liver function test because this anabolic steroid, Danabol, can affect your liver. So first thing I definitely want to do is the liver function test. And as you're taking anabolic steroids, I have to go for hormonal level as well. So the testosterone or LHFSH level we need to do for females. And lipid profile can also be done here. Right. Now, what is the treatment? Treatment is simple. You have to stop steroid. See, it's not only anabolic steroid, even other steroid like prednisolone can also give rise to it. So what happens is, if, for example, if I forget about anabolic steroid, but my patient is taking prednisolone for something else, I cannot stop it, but I try to review the medication, I try to taper it down. But here my patient is taking anabolic steroid, so I can definitely tell the patient to stop it because that is the reason of your acne, right? And wash your face twice daily. Don't wash this too many times. Yeah. Avoid touching the acne, shower after workout, avoid greasy skincare products as well. The medical options that you can offer. See, whenever we offer something in acne, we give a combination of it. Usually for mild acne, what we give, uh, for mild is benzoyl peroxide and topical retinoids. Adapalene, tretinoin, that's something that can be given. And also you can add maybe topical antibiotics as well, right? So it's topical thing that's given. And don't give only one thing, it's a combination that's given. So benzoyl peroxide or maybe topical retinoid, a topical solution you give. Sometimes you can go for topical antibiotics as well. That's for mild acne. If it is moderate, the management is still the same. But if it is moderate to severe, you know what we can do? We might might be able to add oral antibiotics. That's the difference only. So if it is moderate to severe, if it is mild to moderate, you just go for topical thing. But if it is moderate to severe, we may be going for oral antibiotics as well. But if it is very severe acne, you may be able to go for isotretinoin as well. But this is very strong medication. It has got so many side effects as well. It can affect your liver, your kidneys, and it's going to make your skin very rough as well. You can have hallucination, psychosis, lots of side effects are there. So you are nobody to start the patient on isotretinoin. It has to be started by the specialist only. And we don't give isotretinoin or Roaccutane straight away, even in severe acne. For severe acne, we again try to go for topical treatment first. We can go for oral antibiotics, but topical treatment. But if that's not working at all, symptoms are getting worse, then maybe the specialist might start the patient on isotretinoin. So I don't want you to mention it actually, just forget about it. Right? So follow-up is going to be, first I'm going to give topical treatment, but if that's not working, we may consider giving you oral antibiotics as well. But make sure you tell the patient to stop anabolic steroid. Right? And if you get these things in the exam, just check it, because your patient, as I said, may not be saying Dianabol. I'm taking a steroid, it is start from DDD. So you can confirm, do you mean Dianabol? So I think that will make your life easy. So that is your acne, steroid or Dianabol induced. All right. Okay. Urinary tract infection, UTI in a female child. Your FY2 in GP surgery, or again, it can be in A&E as well. A mother has brought her 2-year-old daughter due to fever. See, UTI is more common in females, right? Even if the children, it's more there in female because of hygiene. I'll come to that point. Talk to her and manage. How can I help you? My child has been having fever for the last 2 days. In this country, they are very, very sensitive, I would say, towards children. In the UK, your kid is the government's kid first, and then it's your kid, right? So anytime if you get fever, make sure you rule out everything. You rule out everything. You rule out meningitis. You rule out any abdominal infection. You rule out UTI. That is definitely you need to do. So fever, elaborate a bit more if they have checked it or not. Right. So if they have checked it or not, so that is really important. And is there anything else? Then mother is saying she cries a lot while passing urine. So I think that is something very important again. She cries a lot while passing urine. So I think we understood what is it. It is UTI. So ask Odipara, when did it start? If it is every time when she passes urine, if she's crying, temperature if you have measured, how much was it? Ask more question on UTI as well. For UTI, we know fever is there. Then you can ask about nausea, vomiting. We can ask for cloudy, smelly urine. Tummy pain, I don't think so. I can ask, isn't it? You think the child is passing urine more frequently now, frequency, that is more important as well, right? And if he's crying while passing urine. So, I mean, those things that can definitely be asked, right? So asking more of UTI questions, yeah. Now, what I said, you got one infection, but then you have to try ruling out other infections as well. So ask if there is any rash anywhere in the body for meningitis. If you feel that your child is shy to light, photophobia. If your child is crying while moving the neck, yeah, so that's something. She's having diarrhea, constipation, that's very important as well. Patient is having fever. Are you giving anything for fever? Yes, I'm giving paracetamol. So if it is helping after paracetamol, if she's okay or not. Yeah. Also ask if the child is eating, drinking well or not. Yeah. Playful or not. That's very important. Yeah. Child is not eating, drinking well, then dehydration you need to rule out. And if that's the case, you might be admitting the child as well. Right. So these are the things very, very important. The nappies and all, she is toilet trained, that's good. Sometimes you get this history, and this is very important. I wipe from back to front. We always advise to wipe from front to back. But you're wiping from back to front, that is a reason of UTI. All right. Then what you do, you quickly take board history as well, finish it off. And I would like to do your general physical examination, vitals, and obviously the examination of the child. And we're going to do the urine dipstick test as well. So this is what you got. Temperature is high, nitrates and leukocytes in the urine. What does it mean? It means it is UTI. Right. So what you do is you disclose that it is UTI, and because of it, it can happen. And there are many reasons. And according to the history, what I got is that you mentioned that you're wiping from back to front. So that could be one of the risk factor, right? If it is repetitive, if it is happening again, you might be doing some investigations as well, like ultrasound and all. But for example, if it is just happening once, I think we can start the patient on antibiotics straight away, right? So now what you have to do is you have to see, is it lower UTI or is it like upper UTI? So lower UTI means they may not have severe symptoms. For example, in lower UTI, they just might have a burning sensation while passing, crying. They may not have very high grade fever as well. But when it is upper, like pyelonephritis, patient will have high grade fever, chills, rigors, and pain more. So severe symptoms will be there in upper. So now the treatment is what? Treatment is antibiotics. That's the main thing. If the child is less than 3 months, you need to refer the child to the pediatric specialist. That's the thing. Our child is 2 years. So if it is more than 3 months, what we can do, we can start the patient on antibiotics. You can start the patient on antibiotics, right? So fever is high grade in our case. I think so we can maybe go for ciprofloxacin as well. But if it is like you feel lower UTI, we might go for nitrofurantoin or trimethoprim as well, right? So that is going to be for 3 days. But if you're going for upper UTI, it is going to be for 7 to 10 days as well, right? Again, nobody's going to ask you what's the name of antibiotic. That's okay. If severe cases, when child is not able to eat or drink, dehydration, admit, and you might be going for IV antibiotics as well. That's how it is done. Do not forget to give the supportive management in the end. Supportive management would be wiping from front to back. That's very important. Ensure she drinks plenty of fluids and flush out the infection. Paracetamol for fever and discomfort. Wipe front to back. Changes nappy frequently so the areas remains clean, and avoid bubble bath as may irritate the area. So all these general advices you can give it to the mother. So this is your urinary tract infection in a female child. All right. Okay, let's have a look at the epistaxis, nosebleeds. You have to, in GP, or patient might be coming to you in the A&E as well. So it's 25 years, has come to the clinic because of recurrent nosebleeds. So recurrent nosebleed is nothing to worry about. It's a little area that you have in your anterior aspects of your nose, and when it gets irritated because of maybe it's very much dry mucus and all, and you're picking your nose, and you can have this bleeding as well. Nothing to worry if it is a recurrent nosebleeds. Yeah. But few things that we need to look for, obviously. Yeah. So what are the things you're gonna look for? What brings you to the clinic today or to the hospital? I've been having nosebleeds and I'm getting worried. Okay, tell me more, Odipara. What makes it worse? What makes it better? For how long you've been having it? How many episodes you have got? How much blood you lost? Is it fresh blood? If there are any clots in the blood? Is it from the right nostril, left nostril, both the nostril? How much amount usually? All those questions you need to ask. So what I'm doing a proper Odipara. Right. So what it says, it happens in winter or when I go to the warm, to a cold place. Okay. And last for 5 to 10 minutes, and a small amount dipping from mainly the right nostril. That's a very typical finding that we don't have to worry. Right, so Odipara I did. Now remember one thing, whenever you see vomiting, diarrhea, you rule out dehydration. Whenever you see blood, what you do? You rule out anemia. You ask questions for anemia. So ask about dizziness, headache, okay, fine. Palpitation, shortness of breath, ask those questions. Now, why epistaxis is there? So the reason could be, I would say, nasal congestion, stuffy nose, runny nose, recent trauma, or maybe nose picking habits there, right? So that's something that you can ask. See, patient has got bleeding. I need to look for if there is bleeding from anywhere else in the body. Because if the bleeding from anywhere else, it might be related to any bleeding disorder. So I have to look for that as well. So if you've got bleeding, bruising anywhere in the body, if you've been diagnosed with any bleeding, clotting disorder, if you're taking any blood thinners or not, ask those questions as well. If you've been any recent instrumentation, maybe an ENT procedure, who knows? So these are the questions that you can ask. Another thing that most of us we might miss, but don't miss here. Your patient is a young patient. Please ask for recreational drug as well. Why? What do you think? Why it is so important to ask recreational drug? Why it is so important? The importance lies here. See, what I'm looking for is cocaine. So you can cover that part as well. Sniffing, right? So that's very important. Right, so then I would like to do your general physical examination. I'm going to check your vitals. I'm going to do the ENT examination as well. And we'll be doing a routine blood test, your bleeding clotting profile, iron studies, all those things we'll be doing it, right? So from assessment, you have got nosebleeds. That's due to the nasal dryness or irritation worsened by the temperature changes or nose picking. The inside of your nose has tiny blood vessels that can easily break, especially in cold, dry air and irritated by nose picking. It's called anterior epistaxis, which is the most common and it's not serious. I think most of us also we have had in our life, right? I have had it previously, but yeah. So what's the management? It's gonna subside or so on. So some general advices that you can give. If your nose bleeds, if nose starts bleeding, pinch your nose firmly. That's important. Soaked part just above the nostril for 10 to 15 minutes. Lean forward slightly. Do not tilt your head back to avoid swallowing of the blood. Breathe through the mouth and apply a cold compress. That's things. Apply a cold compress or ice pack, for example. Breathe through your mouth. This is bending a bit front in the front and then just pinching your nose and breathing from the mouth. That's it. Right? So that's something that you have to do. Preventive measures like avoid nose picking, obviously, right? And use a saline spray, or sometimes we do the Vaseline, the petroleum jelly as well. So it's going to make things wet, not dry. So that could be quite helpful. Use a humidifier. Yeah. Stay hydrated. Avoid excessive blowing of the nose. If you need to sneeze, do it through your mouth open to reduce the nasal pressure. That's the thing, right? Medical treatment if needed, it is a saline nasal spray. So it's just for keeping the nasal lining more moist. Petroleum jelly that I've already mentioned, and nasal cautery, that is if it is happening again and again, and maybe ENT specialists can do those things, right? Seek the medical. So when are we supposed to be alarmed? What is going to be the warning sign? When you should go to A&E straight away? Number one, if the nosebleed is lasting for more than 20 minutes. If it is lasting for 5-10 minutes, nothing to worry. That's okay. But lasting 20 minutes, A&E. If it's heavy bleeding or blood running through the throat, because it could be posterior epistaxis as well. More than 90%, it's anterior, nothing to worry, right? If you feel dizzy, weak, faint, or if you have easy bruising, bleeding from any other areas, so you go to A&E. Because if you've got bleeding from bruising at any other area as well, so it is not only the nose, it's some systemic problem, maybe some other bleeding disorder. So go to the A&E, right? So that's the main thing, right? So is it serious, something serious like blood disorder? That's the question that can come from the patient side. So in the history, when you ruled out other differentials, other causes, when you didn't find anything, so you can say, not really, it doesn't look like. We're going to do some blood tests to find out. But the history that you have given me, the examination I've done, it doesn't look like. Yeah. Can I stop these nosebleeds permanently? Yes, it can be. But initially, what can happen is maybe we can cut down the number of episodes you're having at the moment. But if you work on these things like stay hydrated, avoid picking your nose, and what do you say, avoid excessive blowing of the nose and all, using humidifier. So all these things gonna be very, very helpful, right? So that's what you can mention as well. So that's what we have got in the epistaxis as well. All right. All right, guys. So that actually finishes our new station.